very game of I also love how there's just this one chair, like for the peanut. This one. I know what you want. We'll make the best of it. I feel like I've had a secret. I can do it. Here. Okay, right here. Yeah. Yeah. Are you hard to? Oh, okay. Um, yeah, here's my card. I'm sorry. Very trouble parking. Yeah, I tried to take my card. Not this time. I was wrong. Last time I was getting credit with my card and it's never hard to get credit. Credit. Never had accepted it. And I'm like, I've got very change on me. And this is it. So I really didn't just put that. To be honest with you, because I'm part of the very long. And not all people here change on them. And now you're in a position that like my getting to get one of the. Oh, yeah. Here you go. Oh, sorry. Sorry, we can ask that you sit in the first or second row.
What is the biggest state you
A
have?
little closer to us. Thank you, team. Thank you. Thank you. Nice to see you. Nice to see you too.
from two of my homes, yeah. That's good. See you tomorrow, though.
No,
You're not here tomorrow?
no,
Okay.
my daughter's graduating.
That's your, oh my God, in the dress?
Oh,
You showed me.
I still, yeah,
Oh my God.
tomorrow, but,
Actually, oh wait, no, that was for prom, the dress she wore. Does she have a separate dress for graduation?
yeah. I thought it was like,
Just show, I don't know.
go out for you.
Show me on break, show me on break.
Check, is it here?
Oh, okay, yes.
Jojo? No. Good job. And Elizabeth. Art, Warnerson. And Michelle. There's 1, 2, 3, 4 people. Finally. Oh, we're good. Okay, good morning, everybody. Sorry about some of the chaos this morning. Thinking we were locked out of the room and then not being locked out of a room, and then now we're in this giant room, and now I feel like I have this whole stage to try to perform on. So welcome to supporting older adults living with mental illness. It is a full day today, but we're going to try to keep it as engaging as possible. Understanding that we don't really have tables here, which is also an interesting setup for us. But just to kind of give you an intro to who we are. So my name is Sasha Johnston. I'm the Psychogeriatric Resource Consultant, or PRC, very long-winded name. But basically, I support long-term care homes in the downtown core. So I'm out of St. Michael's. So most of my experience comes from the long-term care sector. I do have a little bit of acute care experience, but not as much in behavior management in acute care, but mostly long-term care. So if you hear a lot of my stories, it's usually coming from that context. And with me today, I have the lovely Brittany.
Psychogeriatric resource consultant. I'm based out of Michael Caring Hospital. I started actually as a activation aide in long-term care, then moved into a behavior support lead, rec therapist role in long-term care. Then a case manager. Hi, welcome back. Hello. And then I moved into a case manager role in the acute care setting, and then role here. So thank you for being with us here today, and thank you for participating. It's going to be very fun and very engaging.
Yeah, so we have a day full of learning about mental health, recognizing that, again, we're not really teaching you or facilitating information. You guys have a bunch of knowledge already, and I would love to get to know who's in the room. So I just go around quickly and ask, we have an icebreaker, so let me move it along quickly because I want to get to know who's here. And then we'll backtrack. So we'd like to know your name, your organization, and role. Have you attended any of the other trainings that you see on the screen here? So GPA pieces, You First, or mental health first aid for seniors. And pick one of the following questions. Only one, because otherwise we'll be here all day to talk about those questions because they're fun. But let us have an answer to one of those questions. So if it's okay, is it all right if I start here at the front?
Sure.
All right.
Hi, my name is Susie Meyer. I am with Brent Senior Care as the manager of supportive housing. I have attended GPA and MHFA, and favorite place I've traveled is Portugal. People are so friendly. It's so beautiful. It's the oldest country in Europe, and the food is delicious. Yeah.
Where did you go to Portugal?
I was in Lisbon.
You're in Lisbon.
Yeah.
Amazing. Lovely. Thank you. And next.
My name is T.
And I work for St. Clair O'Connor Community Nursing Home. I'm a RPN and I just taken this role as a PSO lead.
Okay.
So this is my first training.
Okay, did I leave late?
Huh?
Um.
She's working night shift.
Oh, I was very.
No, she's here still, but she work night shift. So
Oh,
that's why she
okay.
cannot attend training or anything in the
Right.
daytime. Yeah.
Got it.
So my favorite hobby. So my favorite place to travel is Hawaii.
Done a bucket. Sure. Awesome. Thank you so much. I'm gonna go down to this end if that's okay.
Favorite place that I've visited, probably this many, but I had to go with the CES thing. Oh, yeah. People. That I'm looking at, so we get up.
Congratulations. That's lovely.
I'm going to Spain now.
Oh, lovely.
Awesome. Thank you.
Thanks for being, and I was with the Toronto Supportive Housing Program based out of Brockville Manor. I've attended Pieces and You First, and the favorite place that I traveled to was Hawaii. I traveled to England with my whole family for a wedding.
Oh, lovely. That's awesome. Thank you. Hi.
Hi, good morning. My name is Sarah Lynn. I'm one of the RPN at the 2 West area in Halifax. Then I have studied GPA and thesis. One of my favorite places that I've traveled to is Portugal too, with Azores.
Oh,
Which island?
Yeah, it's very beautiful, so magical.
It is. Which island did you go to? Oh, that's okay. That's great.
Beautiful,
It's beautiful. Yeah.
magical.
It's one of my favorite places too. Absolutely. Thank you so much.
Hi, my name is Yonit. I'm an occupational therapist. I just recently started on the BSOT team in the coordinating office for triaging. And if I had to delete all but 3 apps, it would probably I would keep the weather app, Spotify, and probably my daughter's class schedule for band.
Nice, practical. I like it. Thank you.
Hi, I'm from Houses of Providence, I'm the Delta. Yeah, I'm the favorite role in the Brilliant Party. On GPA pieces, I'm a GPA coach as well. I was actually gonna do number 4 since no one had did it as yet, but she beat me, but it's okay. I'll keep my Monopoly Go. I'm addicted to it,
Okay.
addicted. I'll keep Spotify because I really do like music and my daughter will sacrifice me if I ever remove that.
Yeah.
And so the next one, WhatsApp, because then I talk to my friends in back home in Jamaica.
Amazing. Okay. Thank you so much.
Hi, my name is Suzette, just a little bit of the people. My background is, and my favorite hobbies are cooking. Like,
Love it. Thank you so much.
I'm happy. I work at the side of the system space, so let's see. I think that would be India. Yeah, that's a thing. Then Rosario, I work at the first and yes, so I have attended already and life and I've been reading all the time.
Thank you.
The one you're working is I work in video significantly. I if I have to
I have to, UKG, which is our schedule to spend.
Okay, yeah, yeah.
And also, my TV.
Oh, your bank account, yes, absolutely, yeah, very practical people, I like it. Absolutely, thank you. Right, I love it, thank you so much.
Attended issues, people, and things to do. My hobby is singing and dancing.
You got a stage, right?
All for you.
When I do that, I don't feel like
I love it. That's great. Well, like I said, we've got a full stage here. I'm more than happy to take some time out of our program today. I love it, thank you.
Hi. Um, my favorite hobby is to work along. Especially my father and the huge challenge in order to mine.
They all love it.
The nice long walk, I was gonna say, skip off, I went already. They would love those long walks too.
Unless they're like 2 months old, they get tired about like after like 10 minutes and then they're a little tired, so. You know, like, I learned that the hard way. I was like, oh, you know, little puppy energy, let's go for a walk. And then she just
Stop it.
exhausted.
What about you, Brittany? You want to answer one of these questions?
Um, I belong, like, really will always be in Italy. The best piece of advice I've ever got was probably like. Trinity to accept things I cannot change, the courage to change things I can. I have a tattoo that kind of resembles that as well. It's a Celtic symbol. But anyways, so that piece of advice is it kind of just teaches you that you can't control it. Right? And if it's like, sorry, if it's out of your control, you gotta learn to let it go. You have to accept it. It's well, like, won't harm you in the long run, but if you can't control it, you can do it better. Okay. Yeah, that's it. Thank you. Yeah.
I have a really hard time with showing what is your favorite place that you travel, because I just love traveling so much, and I feel like every single place I've gone, I still want to be part. One of my favorite places was Jamaica. I love Jamaican culture, I love the food, I love the people, I love the music, I love everything about Jamaica. But I also just recently went to Greece, and that was incredible, and I love tzatziki. I would bathe in that every day. So tzatziki alone still next to my heart, and then also my husband's family is from Portugal, from the Azores, so they're from Stata Island. So I've been there a few times actually, and still have family there. It's a very small island, so I've seen many and like my husband's related to like half the island, but yeah, it's gorgeous. Anyway, so that I couldn't choose a favorite, but those are my favorite spots that I've been to so far. So I will pass the talk to you and take us back to the beginning here. And we'll get started.
Okay, wonderful. So we're just gonna take a minute, everyone, to just go through this list of policies. See the photo. The RGP for regional area We are. The RTPS operates on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Glen, the Chippewa of Apples. This territory is covered by 13 with the Mississaugas of the Credit and is home to many diverse persons, Inuit and Métis. We are grateful for the opportunity to work with communities around important traditional healthcare. We are committed to reconciliation and a restoration of health, wellness, and self-determination of Indigenous peoples, and are taking action to improve the healthcare experiences in terms of older Indigenous peoples. So here is our agenda for today. We will be going through registration, which we've already done. We went through icebreakers. We're going to talk about the introduction, which is module 1. Then we're going to go on a break. We're going to go through module 2, which is depression and bipolar disorder. Then we'll have a lunch. Then we'll go through module 3, anxiety disorders. Module 4, personality disorders, schizophrenia, and then which is module 5 and our wrap up. Although we may recognize there may be some case-specific examples that may require resolution, unfortunately, we will not be. So if anyone has any case studies today, the intent of this course is not to go through specific case studies and provide specific resolutions. Okay. So then the basics.
Look at this way. This way.
This way to you. It's not. Okay, it's not. I was looking for the basic assumption one.
Oh, yeah, I think this would say, you can just say that. So some of the slides in your book may not follow this directly. This is an older slideshow, but it still has everything. It just didn't have a couple of extra slides that we had added. So you should still read out the basic assumption.
So, the basic assumption, we believe that everyone participating in activities today is intelligent, capable, cares about doing their best, and wants to improve care. Everyone brings curiosity and relevant information to today's talk. So our goals for today will be to define common mental illnesses as per the DSM-5, identify suitable treatments, and explore supportive strategies and interventions. Getting to know you, we're done that. So, an introduction to up to date. Okay, so we are going to go through. Okay, so we are going to watch a video on what is mental health.
We all have mental health. It is just as important as physical health. It is not only about mental illness or mental disorders. This is just one part of the bigger picture. It's better to think about mental health as being on a continuum, rather than people being either mentally ill or mentally well. We are all on the continuum, and we move up and down according to factors such as our genetic makeup and upbringing, our life circumstances, and the stresses we're under. At one end of the continuum, we have mental disorders, like depression or anxiety. And at the other end, we have states of positive mental health, when we're thriving, content, and fulfilled. The aim of mental health interventions is to move people up the continuum so that they're able to reach their full potential and live satisfying lives. The World Health Organization describes mental health as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community, being mentally healthy means being resilient and able to cope with difficult times, feeling in control, being confident, feeling good about yourself, managing and expressing your emotions, building and maintaining good relationships. We all experience periods when we feel stressed, worried, anxious, sad, afraid, or angry,
These are all normal emotions. However, when these emotions become severe enough that it interferes with the person's ability to function daily, and these feelings become persistent over time, then it can develop into a mental health problem. There are many different types of disorders. When left untreated, mental disorders can be chronic and long-lasting and are associated with increased disability. They significantly have an impact on daily functioning and frequently interfere with family, social, and work responsibilities. Fortunately, there are effective treatments and evidence-based interventions available that aim to help individuals understand and cope with symptoms of mental illness. However, very few people with mental disorders access existing treatment services. This may be due to barriers such as the stigma attached to seeking help, the lack of understanding of mental health problems, uncertainty of how to get help, or the fear of disclosing mental health problems. Research shows that stigma remains one of the biggest factors preventing people from seeking help early for their mental health problems and getting the appropriate support they need. It is important to acknowledge that we all have mental health and have a personal responsibility to learn how we can improve and maintain our well-being in order to lead meaningful and satisfying lives. Want to learn how you can do this?
So I do want to say one thing, I have a bit of sales of the beginning. You can write the field of them. How would you define? Just watch the video on it, but in your experience where you were your own definition or interpretation, how would you define it? Start again. Go ahead.
Just your general ability to cope positive and negative ways with environment and surrounding day-to-day life, like everything.
Great definition. Wonderful. Yes. Anyone else have anything to add? That's okay. According to mental health and emotional psychological and social well-being, it affects how we think and act, and also helps us determine how we handle stress, relate to others, and make choices. Through adulthood to end of life. Care. So, person-centered care, quite literally, means putting the person first. So we would never want to say anything like, this person's schizophrenic, this person is an anxious, depressed mess. We would want to say person living with depression, person with depression. Unless the person states otherwise, because some people may have their own preferred terminology, and that's still using centered language. If someone there next to students said, no, you can call me a schizophrenic, that's still using centered language because that is their personal preference. When talking about their diagnosis, they're taking ownership of how they would like to express it, and that is okay. But we want to run the assumption when we're talking about it that we're putting the person before the diagnosis, unless the individual indicated. It is important because when we use terms like schizophrenic, depressed, we are labeling the person not as their full identity, when that is only one part of it, right? Just like we would say, if I was to say, hey, Tamara, you would just say, oh, I'm a nurse. You would tell me your daughter's graduating tomorrow. You would tell me everything under the sun of them. You have a GPA and this and that. You would start labeling her to narrow her down to one thing you couldn't. That's not her entire personality or everything about. So, and it's just people who live with, there's also just people who live with a mental health diagnosis or just dementia, and some people have experience in your roles can have those overlapping diagnoses, and we can use the person health as well as people with dementia. So What percentage of older adults would you estimate have some form of cognitive impairment? How many people, what percent of adults do you think have some form of cognitive impairment? Pardon, sorry? 70? Okay. Any other guesses? Pardon, 30? 36, 35, okay, so we have a wide range. So cognitive impairment is a common diagnosis in the population with support, but not the only diagnosis. So the purpose of this slide is to highlight the prevalence of dementia in older adults and recognizing 1 in 5 people living with a mental health condition. We need to learn more about mental health and how we can best support all of those we care for. The reason we often tend to think as care providers that dementia and cognitive impairment is so higher is because we're surrounded by it every day, right? Like that is the environment we work in. So to us, it seems like, wow, there are so many people living with cognitive impairment. There are, don't get me wrong, in the general population, there are a ton of people living with some form of cognitive impairment, but it's not as many as we think, just because we do work in the sector, but in the grand scheme of things, not as we think. But the prevalence of mental health is 1 in 5. That is the fault, right? And that's just the diagnosed statistic. That's not people who have been left undiagnosed or untreated, haven't sought help, don't know where to look for help. Okay. So, what mental health conditions do you see the clients that need support? Schizophrenia, yeah. Anxiety, I hear 2 anxieties, yeah. Bipolar, what else, sorry? Depression. Bipolar, depression, yeah. Anything else? Dementia, yes. Yeah. There's a lot, go ahead.
Hoarding.
Hoarding, yeah, exactly, we do see that, yeah. You work in long community or long-term?
No, I just recently switched to BSOP, but I was
Oh, right.
occupational therapist. Here, I think that.
Yeah, I've seen a lot of hoarding and collecting in my time too, but I've seen it in residents in long-term care, people coming from community to hospital as well. That's something that you see. There's actually a lot of great supports for that as well. So I'm now going to hand it over to my colleague Sasha, so she will go over what.
All right. So we're actually going to start discussing, before we get into the meat and potatoes of different types of mental health disorders, we have to get through kind of the leggy, boring legislative stuff. But recognizing that when it comes to working with people who are experiencing mental health conditions, it isn't as, it's not really black and white with dementia either, but it's even less so when it comes to mental health, right? So when we consider capacity, what in your experience, what does capacity mean? Yeah.
Capacity is a fluid definition, and it is very specific to each individual question that you're asking. So, and it actually is a legal term, so we have to be very cautious about the way that we use the word capacity.
Yeah.
We use it a lot in determining if someone's capable to make a decision whether or not they're going to long-term care. But then capacity becomes very complex when you're talking about financial capacity. And it should really never be used as a very blanketed term.
Yeah, so thank you for getting quite a nuanced term when we consider what capacity means. And oftentimes when we're using the word capacity, we're not necessarily looking at all of the legalities that touches. So capacity is extremely important to everybody in this room. And the idea that capacity can be given or taken away is almost like a very scary kind of idea when you think about it. But capacity really does come into play when we talk about different acts and legislation, which we're going to go into. But when we're considering overall, what is capacity? Well, people are deemed to be capable or have capacity in the most general sense if they are able to understand relevant information to make a decision, and if they're able to reasonably or appreciate reasonably foreseeable consequences of a decision or lack of a decision. So very, very we wanted this capacity. We were looking for these two things in most cases when we're trying to see if people can make decisions for themselves when it comes to particular treatments and also for particular placements, etc. So since the 1990s, there has been a shift away from this idea of global findings of incapacity. So that's another piece that we have to recognize. There is no such thing as a global incapacity. And what that means is that just because someone says in a moment that maybe they're not capable of making a decision at that time for these reasons, that doesn't mean that they can never make that decision again. Or that even in that moment where they can't make that decision, are they unable to make other decisions? So we have to really look at what are we asking, as you mentioned, and what is it that is concerning. So the way I'll put this into kind of play is looking at POAs, because we all work with POAs in some capacity or another. If a POA is put in for care decisions, that does not give them a blanketed ability to make decisions about everything. And often in long-term care, we defer to POAs for many things that we really. For example, I want my mom to eat lettuce every single day. Well, that's not a care decision. And if mom wants to eat chocolate cake and not lettuce, it comes down to whether the person can make that decision at the moment. And I could say that if she keeps pushing or spinning lettuce at me, that's a pretty big determination that this person does not want to eat lettuce. And if they keep grabbing for the cake, that's a pretty good determination that this person wants to eat cake. So we have to recognize that capacity does not mean that suddenly someone loses all capacity to make all decisions. And also recognizing that POAs for others have to have the authority all decisions for a person. And that comes down to things like food or clothing. You have to be careful about how much when it comes to these types of different cases. So I want you to think about it. Can you think of an individual that you support who has either a mental health or dementia diagnosis or both, and is still able to make those certain decisions? Everybody's name should be yes. Absolutely, right? Because again, there is no such thing as universal capacity. And just because someone may not be able to verbally tell you, it does not mean that they can't use their nonverbal to also tell you. If we think about providing care to an individual, how do they tell us that they don't want you to be doing that? If they can't speak, push you away, punch you in the face. There's lots of many ways that we've been on the other end of where people are telling you that they don't want this to happen, right? So recognizing that it's not just about being verbally able to provide. Oh, there we go. A little laggy. Okay, so we have the fundamental principles of healthcare in Ontario, looking at how treatment cannot be provided without informed consent. So we all have the right to make our own decisions, good or bad, right? Things that we consume that we know are not good for us, that might be the best, we might know that we shouldn't eat Big Macs every day, but sometimes you just want a Big Mac. You don't eat the Big Mac and you're like, oh, I probably shouldn't have done that. But you are allowed to make those proper decisions. People are allowed to smoke. People are allowed to drink alcohol. We are all autonomous people as long as you're over the age of majority. But we can make those decisions, even though we might know that those things are not the best for us. So if the person is capable, they can decide to consent or refuse treatment. It's the same thing. I may know that I have, say, diabetes, but maybe I don't want to take metformin. I would rather try to do diet and exercise first. I can understand that if I don't take metformin, it may be harder for me to manage my blood sugar, but I might continue to say, no, I'm going to try lifestyle changes because I feel like that's best for me. And I can do that.
We have the right to live at risk.
Yes, absolutely. And I would rather live out my life at risk than live my life in restraint.
I've heard people say, like, I remember when I first really gave the long-term care for like roughly 6-7 years ago, and I remember that trying to have capacity and stuff, I'll stand up. I really shocked. For this one resident, and they were like, just because they're making poor decisions, doesn't mean they don't have the right to make the decision.
Yeah.
They were giving the example of like if somebody chose to eat frozen dinner every day, you know, little plain everyone dinner. It's not the healthiest option for you. You'll probably run into issues later if that's all you eat day in and day out. But that doesn't mean you're capable of making decisions because you're making for this seamlessly. People who are, you know, like they're like, well, I just want to smoke. You could argue, well, as far as that safe, that this, that. They're prepared for this. You know what to do, what they want to do. It's like I've seen, sorry, side note, I've seen also these debates, and maybe this is controversial, but like on TikTok debates, people bringing forward, they're on TikTok and they're like for people who are like end of life, but they're older adults live at home. They're like, yeah, they like wanted to do stuff their last day. Like I put them, and I'm just like, you know what? Like if they're capable of making their own decisions and like making their role, it may not be the best, but like at the end of the day, they're able to, they have the right to. Thank you.
So if we find that a person is not, so if we say that, you know what, we proposed the whole thing in the act, we set the consequences, and this person is not able to make this decision based on their intellect is or their cognitive ability at that point, or even just a transient state of inability. So whether they might be on drugs, alcohol, whatever it might be, then we can have an hierarchy of people who can step in to make decisions. Recognizing that that is only good for as long as the person is deemed capable. So that's where we have this, that POA is a similar but different, but recognize you didn't have a place for times of the decision maker appointed or step in to make those decisions, or people who are closest to you, and they'll make that decision on behalf of the person. Become important when we're looking at mental health and how people have the capacity through instability and recognize that this is quite a large player for people who are living with these types of diagnoses. So we can like, do you see how I migrate? Yeah, it's just kind of like I'm doing like the opposite way of where I need to be. Okay. So we have types of legislation in Ontario and recognize that healthcare is run provincially, right? So there is variation across Canada, but we do have primacy in certain legislation when it comes to federal legislation. So things like the Human Rights Code of Canada, right? That's primacy over all of these different things. But we do have particular legislation that divides up and protects not only us as the worker, but also the person whose capacity is being. And that's what's really important here, is to recognize that we have to protect people who can have their capacity taken away. And sometimes that may seem like a lot of red tape for us on one side, but imagine being on the other side. We would want this red tape to exist where someone can just take away our capacity. So recognizing that, we have a bunch of different things that we can look at. So one is the Substitute Decisions Act, where people, the SDM criteria and the hierarchy is kind of placed. So what happens if we have incapacity, who becomes the substitute decision maker, etc. We have the Healthcare Consent Act, and then we have the Mental Health Act. And all three acts deal with aspects of decision making, an aspect of mental capacity. And we're not going to go into, a big law class, but we'll talk very briefly about how this could kind of come into play within your role, but also recognizing that the FDM Act allows a capable person to appoint someone to make decisions on his or her behalf during a period of incapacity and establishes procedure by which another person can apply to the court to be appointed when an incapable person has not appointed a power of attorney. The Health for Consent Act is a shift away from global findings of incompetency, and it has the recognition that capacity can fluctuate with respect to time, and it looks at defining capacity in treatment decisions, and also looks at areas of obtaining informed voluntary consent from either the capable patient or substitute decision. I'm also going to talk a little bit more about the Mental Health Act, just recognizing that the act is going to play a particular part in our world, and also might clear up some of the struggle we have in terms of when we're sending people, say, to hospital, or what forms look like, etc. One last thing just to mention, if you are working in long-term care, remember that it is important to be well-versed in the Fixing Long-Term Care Act, recognizing the Residents' Bill of Rights, etc. So knowing those things are also will come in handy. All right. So, Mental Health Act. If we're looking specifically at involuntary psychiatric assessment, how many people here have heard of a Form 1 or a Form 2? All the hands go up. Great. What is the difference between a Form 1 and a Form 2? Does anybody know? Yeah, so person to be held on Form 1 for 72 hours. I know you're reading your book, and that's smart. That's we call being practical. Form 2 is the equivalent of a Form 1, but it is in the community setting. So the difference is that a Form 1 is usually signed by a physician in LTC, or a Form 2 can actually be signed by just because we may not have access to a primary physician or whatever it might be. So we have to open a couple other doors for people to get a form signed from someone in the community, and it's considered a Form 2. But both of them have a very similar outcome. The person can then be taken to an acute care center to be held on an involuntary psychiatric assessment for up to 72 hours. Now, in long-term care, we are often utilizing Form 1s for somebody who's in an acute situation of stress or in an acute violent situation where there is risk to themselves, staff, or other people. Similar in the community. The issue that I've most come into contact with is that long-term care staff get really upset because they send the form somebody out on Form 1, and 2 hours later the person's back at the door, and they're like, "Hey, somebody's here." So I'm here to give you a little bit of insight into why it happens. So if I am going on a Form 1 and I was being physically responsive in a way, I'm trying to punch staff, I'm screaming, I'm trying to throw tables, whatever it is. You guys get a form, the ambulance come, the police come, they take me away. And then everybody comes for me and she's here. And they say, well, she was fine at the long-term care home. And they go, okay, well, we're this was fine, and then they go, in that moment, not actually being any sort of threat. And for any indication that the change for respond or any indication that we have. Now, if I were at the hospital, information from anybody else on this. What the hell is keeping me in a place that already needs more beds? Yeah. You have to provide evidence to say, this person has had a baseline in North Lake of your clearing delirium related to whatever change in baseline you see, blah, 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 blah. Or this person has a history of schizophrenia, they have not been taking their medication, there is evidence to support increase in hallucinations and delusions. This is causing this, 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 and this. You have to provide some sort of evidence to support the doctor to be able to go in front of a tribunal to basically say, I'm just there. So this is often the disconnect that happens between sectors. We believe that we're sending somebody and they're just going, nope. And in the back, they actually have no legal standing to do so. Fair? This is why it becomes extremely important when we look at forms and what we expect from people on the other side. Any questions about that? Yeah. So recognize again, looking at your transfer policy when it comes to Form 1, what are you actually including in the documentation to be sent with this person? And if it's something where you want to know what the story is, they're not going to know either. So you have to go back and look at that. All right. So another thing to look at is diversity community support. So if we are in a situation where maybe it could be in long-term care, it could be in acute care, but a lot of the times it's also in the community, where a person has a situation of risk that presents itself, it is important to be aware of what we also have needs that can come for obviously certain things like an active crime is happening. There is the MSIT team, which is the Mobile Crisis Intervention Team, which is the police, but also a psychiatric nurse. The only issue with the MSIT team is that it only operates certain times. I know it's ridiculous. I don't know what those times are now. I think they actually have been extended, which is great. But I know before it was like, these problems any other time, just Monday, Friday between 12 and 5. So I want to enhance it, does actually reach your community. It's also based on neighborhood or geography as well. It is, yeah. So after we're looking at also like when obviously if there's an active crime going on, you're gonna call it. Yeah. You can mention that it is an active crime where you believe that mental health is a culprit or is an involvement. And if the MSIT team happens to be available, they can make that call, but it's not going to be the determining factor. Right? We also have neighborhood officers, the people who are police, but they can come plain clothes. This sometimes is a better option, especially for somebody who has delusions. If somebody is, so what are delusions? We'll talk a lot about delusions today, but what are delusions? Anybody? Yeah.
Just a fixed belief.
Yeah, so a fixed belief. And usually those beliefs aren't happy ones. Well, they can be, but sometimes they are things like, oh, people are coming to get me, the cops are coming after me. Now, if that is a delusion, and then we have a bunch of uniformed police officers showing up, that may not be the best option, right? We are now feeding into someone's delusion, and they might escalate in that space. Whereas we may want somebody who's plain clothes to come in and kind of de-escalate, have that a little bit more authority and understanding of the situation, right? So we want to recognize that there is complexity in involving emergency services, especially in mental health, right? So there's a lot of stigma associated with mental illness and the idea of violence. And in some cases, the police can escalate a particular situation and may not be the most appropriate resource. If the person in crisis is at risk of harming themselves or others, these are a very appropriate resource. If the person is not at risk of harm, but is in obvious crisis, A mental health professional or team may be a better resource for that sort of situation. So it's appropriate, it's important for us to assess the situation to determine whether or not it's appropriate to involve certain resources. Okay. Any questions about that? All right. Yeah. Oh, nope. Just scratch. That's all me. No, that's okay. I just tried to make it also a scan now. That's all part of so make sure you make yourself aware. Shifting a little bit from capacity, we're also looking at this idea of assessment and frameworks. So many of you have talked seniors. These are a few examples of very wide-ranging frameworks when it comes to dealing with or managing or working with or de-escalating behaviors. A mental diagnosis or mental health diagnosis. We always want to use an assessment to guide us because that helps us to not leave a stone unturned. And if we consider what is the most popular in terms of frameworks and behaviors, we are usually looking at anyone? What is your framework you use to assess behaviors? GPA first, absolutely. So we're looking a lot at the de-escalation strategies in the moment intentions of GPA. A lot of the things are transferable over to mental health, except for the things that rely on cognitive impairment, because not every mental health diagnosis also has dementia. So we just need to be aware of what we're turning over to this population. Anything else? And you versus is really good. This is the sister program of the one kind of leading on, which is PCIS is usually the most utilized behavior assessment tool when it comes to any types of looking at how can we uncover what could be contributing to the behavior that we're seeing. And if we consider mental health as a component of behavior, then we are not only looking at physical, which could be the diagnosis itself and any of the physical things that come along with the exacerbation with that diagnosis, but we are also looking under the emotional section of PCIS. The emotional section is where we look at things like anxiety or depression that could be leading causes of behavior. It is also where we look at the 7Ds tool of psychosis. So how many people here have taken PCIS? Or are you first? Okay, so for those of you who aren't familiar with PCIS, I will give you a very, very quick rundown. PCIS is a 2-day course, so I obviously can't teach that to you in 2 minutes. But what I will say, I just said, no, sorry. No, that's okay. Again, these are just reflexes, and I'm trying not to miss anything. Sorry. Okay, so PCIS is looking at, if you look at the acronym, it's PICS. We're looking at all the pieces of the behavior and what could be contributing factors to the behavior. So the first thing is physical. Physical is always first. We always have to rule out if there's any acute component that's causing the behavior related to diagnoses, delirium, or looking at like a exacerbation or new onset of some sort of illness. It could also be something just like basic needs. There's hunger, pain, right? Those are all physical causes. We always look at physical first. If physical is not ruled out, nothing else matters. We need the physical first. Because if you're going to come to me and say, oh, look, here's a baby doll because you think I have loneliness or boredom, and I really am in pain or have to pee, I'm going to feed you with the baby doll, and it's not going to be effective. Yeah? So physical is always first. After that, you can mix up the pieces. It's fine. You can go in any direction you want, but you're looking at other possible causes, intellectual, losses in dementia, so amnesia, nausea, apraxia, et cetera, et cetera, et cetera. Emotional is where is looking at the component of emotions and also mental illness. Then there's capability, what is someone able to do or able to do? Environment, the world around us, noise, other people, staff, etc. That can be the environment that can be causing behavior. And then the last is social or psychosocial, looking at past trauma, could be cultural, could be religious, could be whatever kind. So in a nutshell, we look through all those different domains, try to find out what could be, or what we believe could be contributing to the behavior. And then we start intervening with certain things and roll things out as we go. Easy breezy pieces in the nutshell. Today, we are going to be looking at the emotional side and specifically looking at the 70s school and its pieces, which is looking at how do we define whether a delusion or a hallucination is actually something we need to act on in the moment, or if this is something that we can let ride for a minute while we work out other solutions. So basically, we're looking at the risk. I'll give you a very, very quick case to show this. So let's just say that I'm one of your residents and I believe that I am the Queen of England. And every time you guys come, I guess it's the King of England now, but every time you guys come in and go, hello, please have tea with me. I would like to sit with you and tell you about my country. Okay? Is that dangerous? No. Is it distressing? See, pretty damn happy. Okay? Is it disturbing anyone? Am I taking direct action? What that means is in the moment, am I actually kind of like doing anything to that acts on being the queen? I mean, technically you could say I'm asking you for tea, but I'm not really doing much. I'm waving, but I'm not really taking much action. Is it jeopardizing my independence? I know there's a far stretch for me, but is it jeopardizing my independence? That seems good. Is it distant versus present? So does that mean is it happening in the past or the future, or is it now? So I'm now think I'm so it's present. I currently think I'm the queen. And is it definite or fixed versus inset? Like, do I really know I'm not the queen, but I want to pretend I'm the queen? Or is it no, I'm the queen, and there's nothing you kind of say to change it on? When it comes to delusions, those are usually definite. It is a fixed false belief. When it comes to hallucinations, some people have insight into the fact that their hallucinations are real. So that's where that one plays out more. In delusions, it's usually fixed because that's what delusions are. Fixed false. Fair? So in this case, does anybody know what the treatment for psychosis is? Yeah. What types of medications? Antipsychotic, no psychosis, right? So, an antipsychotic has many side effects. They're crappy meds. They're pretty bad. They really are. They're awful. So if you think about it, in this moment of me thinking I'm the queen, would you jump to this idea of let's give us antipsychotic? No, because to be honest, I'm quite happy. And if it's not messing with any of my quality of life, I seem pretty comfortable, then we would say, you know what, let's sit back. We have time to see if this escalates with anything else, to see if this, disrupting her in any way. Let's hold on and kind of monitor the situation. Right? Now, another situation. I can fly. I'm going to show you.
Oh.
Let me show you. I can get up. I want to fly. Dangerous?
Yeah.
Stressing? Disturbing? Am I taking direct action? Is it jeopardizing my independence? Is it distant or present?
Present.
Present. Do I have insight? No. What are we going to do in this situation?
Stop.
We're going to act, right? We're not going to let Sasha try to break the window and show you what she wants. Here. We would be immediately saying, okay, let's even get some antipsychotics up in here, right? That is how we use 70s to look at if the first three are a yes, you're acting. Right? Accept? Cool. So the other thing to think about, and we talked about transferring someone on the board, we talked about communicating. So we use SBAR, situation, assessment, and recommendation. We want to be able to communicate things, but we don't need to communicate everything under the sun. If we're going to send Sasha to the emergency room on form because she's trying to jump out the window to show you she's alive, they don't need to know that I had a hip fracture back in 1972. Right? It can be in my medical history, but it's not be part of my emergency SBAR. Fair? What they want to know is what is happening now and what is relevant to what is happening. So that is why SR is actually a really good tool that everybody kind of knows about, but it's not necessarily a written assessment. It's a brain framing of how you're going to give information. So if we think about how SR kind of works, it's pretty brief, and you can write this down. But I mean, it depends on how you're using it. If we're sending something on form, I probably write this down because we want to give that information and we want them to have it and be able to look. So this is just a random script, but hi, Mrs. Smith. I'm calling regarding your aunt who recently had an experience regarding mental health. She's been isolating in her room, crying, and not attending any of the activities she normally enjoys. That's the situation. Okay. Background. As you know, she has diagnosed with depression, Alzheimer's, dementia, iron deficiency. See, I wouldn't even put the iron deficiency in there. It's not, but it's fine. Been on her current dose of antidepressants for 7 years. Yes, health milligrams. We completed it, so that's the background. Then what is the assessment that we've done? We completed a depression scale called the Cornell scale, and your answer by 5 to 7 out of 10. That indicates depressive symptoms. This indicates we need for further support and for depression treatment. And then what is our recommendation? What do we want done about all this? So I recommend we have your loved ones sleep by our GMOT team or a geriatric mental health outreach team for further assessment and medication review as you are her POA. Okay, I always say with SBAR, start with your recommendation and then work your way down. What the hell do you want? And then provide evidence to get it. That's basically how an SBAR works. If you want something, so now what do you need in order, how are you going to convince them that you need it? Exactly. So what we're going to have you do is we're going to have you work on it. You can do this with your partner if you'd like. I can kind of use how you're saying, I apologize. You can work on it on your own, but basically you're going to take what is in here and you're going to put it into an F bar. I believe we give you the recommendation. So the recommendation is we try to send them to the emergency room and recommend them seen by geriatric psychiatry and a serious workup be initiated. So you're going to be building an SBAR on this scenario, knowing that you want the emergency room to have him seen by Jerry Psych and to do a delirium assessment. So based on what you have in there, set up an SBAR, and then we'll come back and talk about it. Is everybody clear on that? Clear as what?
What is this?
Give another 2 minutes. All right. Anybody need more time? Are we okay? Awesome. All right. So in this situation, one of the things I will tell you guys is that I will use this clicker probably about 45 times a day. So if anybody notices where I put it, see me going, just go saturate over. Thank you. Appreciate it. Okay. All right. So, for situation, what do we got?
So we should set it down. Like during the transfer.
Okay.
So get away.
Okay, perfect. So just exactly what you're seeing. Perfect.
And Mr. M has had a recent change in functional status on the background of a relevant technical history of parent schizophrenia.
Love it. Good. Okay. I know it's out of situation. The other thing I want to be clear, it's not super scripted. If you put something in the situation that's supposed to be the background, it's just more about being concise. That's what this is. The like chopping out the crap. We don't need to know the unrelated BS, right? We want specifics. All right. Sorry, can you? Oh, you're trying to get the situation without success. Absolutely. So that could be the situation, even put that in the assessment. That's fair as long as we're getting that across. Oh, it does it all. Okay, background.
Just carrying on the system right now.
Yeah.
And also here.
Yeah. Over here for a sec.
So first thing, that's the
Oh, just yeah, sorry, there's a lot of acronyms for this. I was and which three? Yep, diabetes mellitus, yep. Hypertension, yeah. So we could, if we're sending to emerge, it's probably relevant to put in anything that we're treating, because at least then they would be able to relate to their MAR. So I would say, yeah, that's perfect. That's perfect. Yeah.
So just that he's a 75-year-old male with a past medical history specifically significant for the paranoid schizophrenia.
Perfect.
I would also mention if they're English speaking or any language they're speaking and what antipsychotics are in place. So as the mainly because it mentions that they did try to de-escalate, assuming that they tried multiple different strategies, including pharmacological intervention, and it has not worked, and that's why we're escalating to we're actually asking for.
Beautiful. Love it. Okay, what about assessment?
Apology? These fundings.
Yeah.
That's my assessment, that's see that funding. That you were saying project of the point in
Yeah,
kidnapping, the not.
yeah, so that could also be in the situation. You could say he's having these delusions. It could be in the assessment that you've noticed it, that you've assessed the situation. Yeah,
So that's like, piece of mental food and plus the pills have already started.
in the garbage. Yeah.
It didn't really say that any of the, that's when I would do, are you gonna make a process of food or you just going from the script?
We go for the script, but you could also add like something that you feel like you could have done. I know you had mentioned, sorry.
Yeah, so I was just gonna say that this is a departure from his plan, so this is an
Yeah.
acute situation. We're noticing that his intake has changed, he's not compliant with his medication, and that we've approached him, so we've actually been agitated behaviors, responsive behaviors, including irresponsive behaviors, so he's threatening and throwing his locker, verbally responsive behaviors, so he's shouting, and also delusions that are quite clear, so he believes that we are going to poison him and that we're from the government, and so I would list all of these things, including specific examples.
Okay. In terms of assessment, so you just say like, can we make up an assessment? What kind of assessment would you maybe want to do here? Yeah, that's easier, right? Having delusion. It's dangerous. It could be, yeah, and it's definitely disturbing and taking direct action, right? It's also jeopardizing his independence.
I would want to be able to process mental see his blood sugar or his vital signs. So it's not allowing me to control them.
Always remember physical, right? But that's another thing too. So we talked about the change in the baseline, change in intake, change in medication use. If those changes are acute and then we're seeing a behavior, what would that be? Delirium. That's why we're asking for delirium work. We're noticing that there's these possible physical contributors that are now we see it could be as an exacerbation of the schizophrenia. Absolutely, it could be. But it could also be an acute state of psychosis related to delirium. And we always want to rule out physical first.
Or
always.
UTI.
Exactly. It could be UTI, which is related to delirium. So we had, it may seem cookie cutter. They say, oh, schizophrenia, delusions, and abrupt behavior, hallucinate. That's gotta be a schizophrenia.
That's all we're seeing and yeah.
Right? That's all we see, and we can become very clouded by diagnoses. We need, this is what happens in dementia care a lot too. Oh, well, they have dementia. Oh, well, they have dementia. Okay, but they also have a body, right? And shit can go wrong.
Yeah.
So we want to rule up physical always first, always. That's why we want to do a delirium workup. We need to make sure that physically this person is stable. And then we move along to, okay, let's see about if this could be an exacerbation of this, for sure. Good job, guys. Yeah.
I have some question, like, I know you can't really give a definite answer and stuff, but I just wanted to know, like, say if we had a situation like this, right?
Yeah.
Would you think that we should call, like, the doctor to get, like, the staff medication before sending them out while we're waiting? But then sometimes what I find, if we do get a staff, because then they won't be able to reach out and bring their physical down. Because in that moment, waiting for the responsive unit to arrive,
Yeah.
it could go worse, right?
Yeah.
But then if you get the staff medication and then it goes to the emergency room, then they're like, hi, I'm fine.
That's where you, so this is the thing. It's a two-pronged answer.
Yeah.
What I will say is that it's always risk first. So if this person is actively causing harm to themselves or others, where it seems like this person can start throwing his locker for other residents or the staff or whatever else, I would say always mitigate risk first. I understand what you're saying too, because now we've treated the problem in the sense where we've now sedated them in terms of the antipsychotic. That's where your notes come in. That's where you say, I've given this, same as an IM normal. I've given this, this is why, but this is everything else that you need to give me that. So we can still ask for what we want, even though their presentation, maybe now they're sedated, maybe now they're not as behavioral. If you have the collateral information to tell them why they're there, that they can provide this evidence and say, we need to do this. See if we can do it within 72 hours, because now this person's on a forum. If we can get it done within 72 hours, for the clear. But if I have to extend it beyond that, I at least have something to help support them. Does that make sense? So I would always say, I understand where you're coming from, because you're like, oh, I want them at the hospital to see this behavior, because then you feel like you have a bit more like traction in terms of getting what you want, but never at the risk of the person. Is that fair? Any other questions? Does this make sense? All right, perfect. So just so that you guys know, yeah, we have another example here, whether it's the same as you or not. The whole idea is you guys had everything in there just to provide what was the situation, what would we do, and then how do we get what we want out of the part of the situation. At the end of every one of your modules, you will have a section that's called resources. So these are all the resources that are kind of related to the content that we just covered in the module. So the information of the different healthcare acts, the long-term care act, the GPA pieces, mental health first aid. This is just to give you, if you want to look into any of these things that we've talked about, there's the resources for you. And then we also have a references page, which just tells you the stuff that we used to create this module. We just like to let you guys know that each module will have those two pieces at the end, and they are in your workbooks. So with that, I know capacity is a larger section, and it usually takes a bit of brain power. So why don't we take a 15-minute break, get a good stretch in, and then we're going to jump into the actual mental health diagnoses. It is 10:05, so let's come back at 10:20. Please be on time so that we can keep things on time. Good to see you again. Oh, I want to say guys now. So there is a coffee shop and a cafeteria. The cafeteria is now open. Reminder that this is a kosher facility. So if you have non-kosher food, they do have a non-kosher lunchroom that you can take your food into to eat. But not elsewhere if you have non-kosher foods. In the cafeteria, there are kosher products that you can buy, kosher food products. And then there's also another little cafe, coffee, water, I think there's some snacks or whatever, closer to the parking lot entrance. So I'm not sure which way you guys came in. It's a little further from here, but there are those two options. Walk-through, if you go out here to the right, to the left, there's walk-throughs there. And if you need anything else. Yeah, no. Yeah, so you go here, go right. Yeah. So I give you back to the GPA. So it's like because so
Visitor parking. Hot thơm là bao lâu? Per hour. Oh. Bị bạ là nhìn lên bên ngoài nó cũ thôi, vô trong nó đẹp lắm, mới lắm. Canada nó xây hay gì? Nhìn bên ngoài xấu như ma, bên trong thì nó đẹp hơn ngoài. Giờ mình nghĩ ra Hello.
The front, where would the front?
So I've seen this happen in hospital and in long-term care. You do see the effects on their mood of those experiences of losses, and when they're told, and I can only speak from the long-term care and hospital experience. I did work a little briefly in community as well, but where you see, you have a resident, you're like, okay, you have to stay. You have to stay in the room. I had one resident in the hospital, who was like, okay, you have to stay in the room. To be fair, he was on contact for all the precautions, but he was willing to wear the full PPE to get up to go outside. Through advocating for him so much, we ended up being able to take him outside with security and so he could get some fresh air, and he was wearing the full PPE. But oftentimes you will have residents who are able-bodied, who are of sound mind, or capable of making decisions when it comes to going out, like, stepping outside, what they want to eat, things like that. And when they feel restricted without a rational explanation, like, oh, you can't because you're an older adult, and because, oh, you're a risk, right? Or, oh, you have dementia. And there's so much stigma associated with that. I'm not laughing because it's funny. I'm just like, you really think about it. I remember I worked in long-term care too, and there was this one gentleman, it was during the pandemic. And I remember he was like, just wanting to go outside, just wanting to go for a walk. They're just like, no, IPAC, like, you can't, there's a risk, your floor is on outbreak. And he was like, I don't understand, I'm not sick, why can't I go out? And we put all of these barriers on older adults, they're adults, they're adults. And we're restricting them sometimes like they're children. Right? Like they have, and no, can't do this, can't do that, you have to ask permission when they're adults and you know, sometimes when they are able to make their own decisions, with certain things, or even with everything, and we're treating them like little kids, and you know, it can be very distressing and very upsetting, and it can lead to or contribute to worsening depression as well. Pardon? Yeah. Yeah. Yeah, no, and there, of course, are guidelines. But that's why it's also important to know the Fixing Long-Term Care Act too. It's challenging because there's a lot of acts and rules and regulations that sometimes cross over one another, and you're posed, that's where we're posed with ethical there. Right, where it's like, okay, Ministry of Health, yes. If your unit's on outbreak, or if you have a few residents that are on outbreak, that one resident is maybe willing to follow all of. Anyways, that's another topic for another day. I could go on and on about that too. But if someone you are supporting is showing signs of psychosis, it's important to ensure that they are closely monitored and get the treatment. All right. Flipping this is not a fun time. Okay. So has anybody heard of sticky caps before? Just raise your hand. Has anyone heard of this? Amazing. Okay, so this is a way that we can screen for depression. So sticky caps is exactly as you see here. This is what it stands for. So sleeping too much or too little. This can just be, it's not, you know, oh, I take a nap. Sometimes I take a nice little 5-hour nap. That doesn't necessarily mean I'm depressed. But when you notice, it's like when we no, that's not a weekend. That's a good nap. But so when you're looking at, is it a change from their baseline as well, right? Think of the use of a dementia observation sheet that is used for people with dementia, but you can track sleep, right? Like I noticed that, you know, they're going to bed earlier, they're sleeping for 13 hours a day. We want to question, of course, the physical symptoms first, but once we rule that out, it could be depression, right? And especially in our older adults too, it's something that often gets overlooked. It's not a normal part of aging. Little interest in activities. So there's something known as apathy, and there's apathy in dementia and apathy in depression. But the way that they're defined is different. With apathy and depression, it is related to motivation and yes, motivation and interest as well. Right? With dementia, apathies, you kind of just need to be their push to start button. You know, they want to do these things, but you just kind of need to push them to do it and make it more enticing for them. But with depression in people who have a mental health disorder diagnoses, it is related to their they don't have any interest in it. So they're like, oh yeah, I used to love it, but I just don't see a point. You know, where's the time? I don't have the energy for that anymore. How would I even get there? I don't want to take the bus. You know, that takes too long. And there's all these reasons why not. There's excessive guilt. What do you think is meant by guilt? Guilt in relation to depression. What do you think is meant by this?
Bad, so not able to see friends and family, not able to get out of the shower. It could be like something that they did for a loved one, you know, a regret of not able to live the life that they wanted to do, or mistreating somebody, you know, something.
Yeah.
What did I get? Right.
Yeah.
You know, from leaving my home or responsibility to here I am with the nursing home, you know, where maybe my career is basically, there's no one I hope that I know, you know, I'm sick, that kind of.
What conditions are the biggest causes of behavior in older adults that serve? It is a huge change and a huge adjustment here. So, it reminds us to explore the person's thought patterns around worthlessness, hopelessness, etc. And how one, so yes, around what you're saying, like, how did I get here? Maybe guilt around family, friends, something they said or something they did. And it's that, like, if they're moving in hopeless, right? Like, what is this? Like, now I have to live this life in long-term care. How did I get to hospital? How am I decompensating so quickly? Where that's why a lot of behaviors as well come from boredom, right? You're not feeling like you mean something, you're like you have a purpose, and we need to give them that purpose as well. Then we have how energy is depleted. So with depression, right, your mood, of course, we know mood changes and your energy depletes. It goes down, right? So sometimes there's, where they all kind of go hand in hand, sleeping too much or too little, right? So if they're sleeping too much, maybe that their energy levels go down. So then you may see that lack of motivation. And then it's like, it's almost cyclical, the hopelessness, the worthlessness, the motivation to do things to make them feel hopeful, to make them feel a sense of worth and purpose, but then they're too tired and they're unmotivated, and it goes kind of circular and hand in hand. And so that's where things like the non-pharmacological strategies, or in some cases antidepressants, come in handy. What other diagnoses come to mind when you think about concentration or memory? ADHD, yeah. What else? Yeah. ADD. ADHD and ADHD. Yes. Exactly. Yeah. Yeah.
Sorry, but like, I also want to say, feel that I did something bad, changed, I am bad. And I do see a lot of state.
Yeah.
Yeah.
Yeah. Shame can be a part of it too,
Yeah.
right? You still have,
Oh, I'm saying it's.
Yeah.
exactly. Shame can be a huge part of it. Feeling like,
And I think go hand in hand in the sense somebody says like I'm burden.
Yeah.
I feel guilty
Yeah.
because they feel shame, right?
Yeah.
Like
Totally.
yeah.
and they were taught that their needs don't matter, that they should advocate for themselves. And how many older adults we work with are like that. That's even a trauma-informed care practice. The older adults you serve may literally never ever tell you or anyone they love about the experiences that they had, because they do, they're victim blame. And they came from a period as well where it was all like hush hush, don't talk about it, be a man, like grow up, it's not that big of a deal. No worries. And all these other um, and all these other perspectives around it too. So there, a lot of times people were forced to shove down their feelings, to shove down their emotions, they're not talk them and press them, right? And then go on, life goes on, you have kids, you have a job, like, figure it out kind of mindset. Appetite increase or appetite loss. So just like with anxiety, sometimes with mood, your system is slowing down. So with depression, you're sleeping more, you're not burning as many calories, right? Even just sitting here, getting up, coming here, you're burning calories. You're not burning calories, you're sleeping all day, you're unmotivated, your body's just using the reserve of what it has. There's not as much need for more food, more energy, right? Sometimes it's the loss, sometimes it's increase, just like under acute stress, sometimes you get really, really hungry. It's the same with depression as well. And then you may have psychomotor problems or suicidal ideation. So suicidal ideations are just the thought of suicide, not necessarily any action or plan. So it's just, oh, I don't really want to hear anything. I don't like it here. I wish I wasn't around anymore. Things like that. But if you were to be like, oh, what does that mean? Oh, I don't know. I just, it's not that big of a deal. And they may be talking about it in broad terms, in general terms. Or they may say it directly, like, I just want to die. To elaborate, they couldn't necessarily for a concrete way they would go about it, or they don't have the means. It's more just the thread of that thought process. Okay. So how can depression look different in the older adults that we serve?
Ageism can play a role in normalizing signs and symptoms of depression. I said that in the last slide, right? We want to really drive it in here that depression is not a normal part of aging. So if you see someone who's showing these signs and symptoms, oh, they're just older, like, of course they're going to be tired, they're 85, that's normal. We want to look at that as not, they're sleeping a lot less. For any of the city cap signs, it is not a normal part of aging. Often people may not recognize anxiety as a manifestation of depression, but we know the two can go hand in hand. How do you think anxiety and depression can go hand in hand? Go ahead, and then you can go too.
My sister,
Yeah.
when she got pregnant,
Yeah.
she goes through depression with her
Yeah,
early.
postpartum. Yeah.
No, early.
Pre,
when she-
okay.
yeah. And then she's very anxious. She keep calling. I don't feel well. I think I get depression, this and that. Yeah,
Yeah,
just early stage of depression.
it can be very cyclical. You were gonna say too.
You know, things are different, but a lot of times depression comes from a place of loss, things that you have lost, things that, you know, you're going through a long time, and, you know, anxiety, things that turns hopefully, now you're frustrated, hopeless, you know, fear, or so you hope, you know, I'm full of that place of loss, I'm full of that place of worry, that place of you want something.
That last one, that's exactly where usually don't matter. So it's making you, you know, maybe you're feeling guilt, maybe you're feeling shame. So because those are such strong emotions, and negative emotions too have so much more weight on our body than positive emotions. So sometimes we have, you know, you're like, oh, I have nothing to do, like I don't even have a purpose. Why am I here? But then somebody's like, oh, well, why don't you come with me to supporting older adults today? Like, oh no, because you know, I have to get up and shower and that's just so much effort. And then, you know, they sometimes, it's not actually a good example. I think social anxiety is a really good example, actually, of where depression and anxiety can overlap. It's like sometimes with depression, you have loneliness, right? Social isolation, loneliness. But then if you have social anxiety, in order to solve the problem of loneliness and isolation, you have to be a little bit social. You have to interact with people with common interests, shared interests. But then when you have social anxiety, you're like, oh no, can't do that. That makes me so overwhelmed and so emotional and so stressed at the idea. Like, for example, coming to talk in front of people today, it's like, no, can't do that. Right. But then that is the way that you would become less lonely. And it's almost cyclical. So your depression is feeding into your anxiety is feeding into your depression. And at some point, we have to look at how can we that cycle to meet the needs of both. How can we combat the anxiety while also treating the depression as well? Can you think of any examples of physical complaints you have heard from the people you support? Examples like pain or fatigue when it comes to depression. Maybe physical symptoms that go ahead.
It's staying, and because they're staying, they can stay up, stay. Or what the process of staying up, when I'm saying this is stay, we cannot hold to, meditation and get, I'm saying, because, the fear, staying, really, a good part of the climate, so I'm told, because something things that come out, get you ready. You know, there's a frustration that, so, responsibility, what is the responsibility that they can, maybe they try to show that to keep you on thing. And I've seen a lot of referrals just for one major event, and they did not see that this would be the root cause, so they can't give a specialist support. And sometimes when it's just, you know, Sunday school at the time.
I'm sorry, at the beginning, we just briefly introduced ourselves and what's sorry, do you mind saying your name and your role? Because you're talking about referrals and everything. So just so so everybody knows.
I, CSW, I work directly for.
But yeah, exactly. Sometimes it is just pain, the idea of overcoming that pain or knowing, oh, if I get up, yes, go ahead.
Oh, no, I wasn't gonna have, what do you think?
Oh.
I have my hand up when you're finished, yeah.
Okay, perfect. So yeah, just, sometimes it's that anticipatory anxiety too, right? Like, oh, well, if I go shower today, that means that I'm going to have to get up and endure the pain, and I'm really nervous. I don't want to endure the pain. I don't want to have to ask for help, so I'm just gonna stay in bed all day. Go ahead.
Oh, the majority of my patients in an acute depressive episode, it's always like a generalized diffuse thing. It's total body aches, it's everywhere, everything hurts. And it's not usually, like, the pain is very diffuse, it's not one specific part.
That's not necessarily, I don't necessarily.
That's why we also need to rule out this, like, the first possible, about pieces. We have to rule out the physical causes. This piece, we go, or is it psychosomatic, right? Is it related to depression, or is it something that is treatable through some sort of pain medication, physio, or tea, or something else? So it may be more difficult to treat because comorbidity can often complicate the picture. For example, somebody who has had a CVA may be at high risk for developing depression, or someone who is on certain medications may need their med list reevaluated. Additionally, for some individuals living with chronic and persistent depression may require a combination of medications to treat depression. As an example, in addition to their antidepressant, they may require an antipsychotic. You may need to refer to a geriatric psychiatrist. There can be a diagnostic overshadowing between dementia and depression, and oftentimes it may be assumed to be dementia in older adults. So a lot of the times you see an overlap in symptoms with depression and dementia as well, like depression and memory too. Older adults commonly experience cognitive complaints or deficits due to depression and may perform poorly on AMOCA, even if they don't have dementia. If depression is treated, memory and cognition will improve. So please note dementia and depression can also co-occur. So when it comes to treating depression with medications, it is not a one-size-fits-all approach. We should always think in general, health and dementia, one person, one plan. We all come from different backgrounds, right? We all have, we were born and raised all very, very differently, even sometimes twins, right? You could have twins and they could be, they're two own individual people. They would need two separate plans of care. So sometimes trial of new medications may be necessary in order to find the right one for the right person. Improvement will be seen in older adults for a period of 4 to 8 weeks. I want to really hone in on that 4 to 8 weeks, 4 to 8 weeks. And I say that why that's important because I've seen many times in long-term care, in hospital, we are often so fixated on a quick fix, right? Resident has behaviors, why aren't they? Well, I tried this and it's not working. Medications, if they're on a trial of medication, 4 to 8 weeks. Let me tell you, there is no quick fix for any of these diagnoses. You can expect 4 to 8 weeks for pharm and some non-pharmacological approaches to work well. So we have to keep that in mind, and that has to be part of the knowledge translation that we give to our staff that we work with as well, right? The behaviors are not going to go away tonight, tomorrow, next week, the week after, maybe not even next month, because guess what? What happens if those medications don't? The ones that you just tried for 48 weeks, you're gonna have to try another medication, another dose, another non-pharmacological approach, right? So it can take a very long time for you to see results in your resident's mood and their behaviors as well. So there are other types of therapies that work, like psychotherapy. So talk therapy is known to help people with depression, but there's often lack of availability of talk therapy. As we know in our healthcare system, it is great, it's better than some other countries, However, there tends to be a very long wait list for things like mental health clinicians, geriatricians, psychiatrists, psychologists, counselors, etc. If you don't have coverage at your work, which actually I know quite a few people who don't, or they don't have a GP, some people don't have a doctor too, right? To find that resource to get yourself referred to a therapist or referred to somebody to talk to, and then on a wait list. And then if you have the money for it, it's not covered by OCHIP, right? It's a long process. Sometimes that in and of itself can be very unmotivating to seek help, and people are going untreated. Then there's repetitive transcranial stimulation. So a more recent form of electronic brain therapy requires a magnetic generator or a coil to be placed near your head. It emits a small electric current called electromagnetic induction. It too is used for people who are not finding the right medication or who are actively expressing wanting to die by suicide. Some resources that could be helpful to your residents are, but not inclusive of, social workers, psychiatrists, or your geriatric mental health outreach teams, a psychologist or cognitive behavioral therapy, local support or groups, your psychogeriatric resource consultant, Sasha and I. I'm not all of your PRCs, but I know I am a few of your PRCs and Sasha as well. You do have one if you are we are long-term care specific. So if you are in long-term care, then you will have PRC assigned to TA. So a 2008 study funded by the National Institute of Mental Health and led by Dr. Melinda Stanley found effective methods of adaptation, including having patients repeat information and make reminder cards, using spaced retrieval during therapy, a method by improving recall by asking questions at regular intervals, which requires the patient to engage their memory. For example, they might be asked, "What's your grandson's name?" or "What is your address?" Shortening sessions to 30 to 40 minutes rather than the standard hour, only practicing 1 or 2 skills per session, and having the patient's care present during these sessions so that they can implement skills learned at home, providing simple written instructions that cover the skills learned and a clear, manageable plan for practicing each skill set between. All right. Supportive interventions. So you can modify the environment, like therapy, for example. Listen, many people, diagnosed or undiagnosed, go through what's the diagnosis? SAD, seasonal, yes, you knew that. Seasonal affective disorder, right, through the year. Your mood changes when it gets dark at 4 p.m. A lot of ours do, right? Or you wake up, it's dark, you're not even home from work yet, it's dark. So things like light therapy, there are specific lights available. I know somebody here said they work near Broadview. Yes, there's this was from years ago, so I don't know if it's still true. But at the Broadview and Girard Library, they have light therapy available there. So to take clients, they have specific lamps that promote light therapy and help with that. When it comes to relaxation therapy, so things like different styles of deep breathing, meditation, practicing gratitude, manifestation, if you believe in that. I do. So for example, like box breathing, we can even take a moment to do that. I will tell you how it works, and then you can modify the increments that you do it in if you have respiratory issues or your residents do. But box breathing, for example, is a way to naturally and manually slow your breath down. It's showing your sympathetic nervous system that you're safe. So you inhale. If anyone wants to do it, you can. I'll instruct you through it now. So you inhale for 4 seconds. So 1, 2, 3, 4. Hold your breath for 4 seconds. So 1, 2, 3, 4. Exhale for 4 seconds. 2, 3, 4. And then you repeat until you feel better. Again, if that's too long for you to hold your breath, knock it down to 2 or 3 seconds. If you want to do more, you can always do more too. So that is just one example of how we can help our residents manually relax. You can also do things like the 5, 4, 3, 2, 1 method. I think it's 5 things you can see, 4 things you can hear. I forget the exact number, but it uses all 5 senses, and I think it's 1 thing you can taste. Because we have 5 senses, that's why it's 5 things, and it helps us bring ourselves back to the present moment. So we have to intentionally focus on something else rather than what's going on in our minds. Light therapy, self-help books, self-affirming interventions. So for people with depression, for example, just changing your mindset. I'm worthy of love. I am worthy of somebody listening to me. Somebody taking time, I'm worthy of healing from this pain that I experienced in the past. I am worthy of time and patience and kindness. I am a kind person. And just saying this out loud to yourself too will help retrain our brain to automatically look for signs of safety as well. Computerized therapy, such as a mood gym or a together ball, formerly known as Big White Ball. Behavioral activation, so pleasure in activities and or mastery of skills when designing activities. So like the activities that provide a sense of accomplishment. So for example, trivia, right? You're like, okay, we're doing 50-question trivia. We're doing Canadian trivia. I worked in long-term care and I was in activation at one point. And I remember this one lady, every single trivia question she knew. She didn't even let other people get a chance, but it was this experience. And I remember, and I would be like, you got a little, and she would laugh, right? Obviously, if you're in recreation, any of you work with residents, you know who you can joke with and who you can't. I'd be like, you got to give other people a chance. And she would laugh because she like knew exactly. She would know everything. I'm like, hey, wait. And like, she was so good at it though. And it's like, that sense of accomplishment from seeing her succeed and know all the questions, like she loved it. She loved it. It was just honestly such a beautiful experience. So, are participating in baking, honing in on your residents' skills that they previously had, and if anyone's taken dementiability, a dementiability focused approach. This could be for residents without dementiability and other physical impairments as well, but just focusing on what they can do rather than what they can't do, and knowing that there's no right or wrong way of doing things. So if your resident with depression is like, I can't color anymore, my hands don't work, you don't understand the pain, like I used to be so good at it. It's like art is up to the interpreter. It doesn't matter, right? Be like, I want to see you color. I'm sure you're better than I am. Focusing on and helping with, you said your OT, right? So focusing, maybe getting bigger coloring utensils, like big thick crayons. Maybe it's about getting like, there's like sticky things you can get on chopsticks, or like those little rubber things you can put on pens and pencils as well to help with adaptations for people who may need that as well. Eating a balanced diet and avoiding alcohol. Of course, diet is up to the specific resident as well, if they're able to make those choices, if they want to pursue that too. But of course, we know food does contribute to our mood as well, right? Like we talked about capacity earlier and eating healthy. Yeah, you can make the decision to eat McDonald's every day, but your energy level will probably be down compared to if you incorporated a couple of fruits and veggies and fiber in there. You might feel a little better. It's not that you can't. I'm also not here promoting diet. I'm saying that if you eat food that makes you feel sluggish, it will, of course, impact your mood too. All the time. And then meaningful activity. I could sit here and talk about meaningful engagement till I'm blue in the face. I'm just going to summarize what a meaningful engagement is from a recreation perspective. Is the question that always stood out to me was, if I were to ask each and every one of you to tell me about yourselves, right? Chances some of you, because of the setting we're in, may sit there and say, oh, well, I'm a nurse, I'm a PSW, I'm OT, I'm PT, I'm director of care, and you might start with your job. But if I were to pull you aside on the street and say, tell me about yourself, chances are you wouldn't start with your role. I'm a mom, or, I am a soccer coach, or I am this. That is what meaningful engagement is. Because if you, let me finish though, because if you were to go into long-term care hospital, it is about your personhood, who you are at your core. I like to knit. I like to crochet. A bunch of you like to travel to Portugal. right? So maybe a nice Portuguese dinner would be nice, or doing a travel log activity. Can you share your experience about Portugal with me? I would love to hear it. I'm talking about Portugal today, and I would just like, if you have any photos, I'd love you to share them with us. That's meaningful engagement, who you are at your core, and using that to, based on the individual's remaining abilities and strengths. Kind of very short-winded version of meaningful engagement. So some more supportive interactions. Great. So prevent tasks in small steps and encourage the person to do what they can at their own pace. So this is sometimes where dementia and depression can overlap, because if you have apraxia can be, even if you don't have dementia or depression, it can be in other diagnoses, but it's the loss of purposeful movement. So if you were to break tasks down, it would be into a step that, let's say, you're teaching somebody to tie their shoe for the first time. So you'd want to say, okay, lift the tongue of the shoe. Then you slip your foot into the shoe. You want to make sure your ankle is in the shoe fully. And you want to take the 2 strings, you want to break it down as simply as possible. Sometimes you might even want to set it up in photographs. Step 1, put your foot in the shoe like this. Step 2, do this. And you want to show them exactly step by step. If you're ever like, oh, is this too many steps? Probably not. Okay, it's better to be as detailed as possible. Yes, short and simple, but also as detailed as possible. Allowing the person to talk and express their concerns. We always want to practice active listening. That is listening without the intent to respond. So if you're sitting there and you find yourself listening to your residents and you're like, that's not active listening, you're not listening, right? You can take notes along the way. You can do other methods of trying to write down, so if you know you want to say something, but it's actively listening without the need to respond in that moment. Because sometimes what makes people feel better is just talking, is literally just giving that person the space to feel safe, freely expressing themselves. Don't take things personally. They're angry or irritable. You are dealing with older adults. They have many years of experience before being in your care today. So chances are, if they call you a mean name, if they say something offensive, I will be the first to say, I'm not saying you can't be offended by it. I'm not going to sit here and tell you your feelings are invalid or that it can't make you uncomfortable. It definitely can. What I am saying is, it's probably not personal, right? When we're dealing with people who have multifaceted brain complexities, whether that be cognitive impairment, a form of cognitive impairment, depression, anxiety, etc., or any other comorbidities, chances are this is from years and years and years and years and years of their own coping mechanisms, right? Of thought processes that are very outdated compared to today as well, ways that we don't think, believe, behave, or act in today's world. Necessarily. So oftentimes it's not personal. If they do say, if they're yelling, you screaming at you, swearing at you, etc. We want to give positive reinforcement. So for good behavior, thank you for being patient with me today. Thank you for saying that. That was very kind. I really appreciate that, right? Because if you praise the good behavior, it positively reinforces that it will get rewarded. Provide choices wherever and whenever possible. Provide residents with structure to reduce anxiety. So often anxiety comes from something being unpredictable, right? Our underestimation of our ability to cope. So when we think, I don't know what's going to happen, I don't know what they're going to say, I don't know what they're going to do, I don't know how my day is going to look, you can get very anxious from that, right? So when you start providing your residents with a structure of some sort, like we have 8 a.m., get up, 9 a.m. breakfast, 10:15, 10:30 snack, this, and that, it's creating predictability and routine and giving your residents comfort in knowing what's going to happen. Then assist them to see they are unusually sad or blue. it is okay for us to point that out, because it's showing that we care and it's bringing attention. Another strategy in self-care is naming the emotion. So if we say, I noticed you're really sad lately, you've been crying a lot, right? If you want to talk about how you're feeling, giving them the opportunity to talk as well, and provide accurate information about depression. So good psychoeducation. Beautiful. All right. So. Okay, so we're gonna do an activity together in just a moment. So exercise and moving our body is proven to improve our mood as it releases happy hormones known as endorphins. Even just taking a short walk, quick stretch, can make a significant impact on how you're feeling. Regular physical health conditions or pain, I want you to listen to your body first. So you genuinely can't do this what's going on, no problem, that's okay, stay seated. If I just sometimes that's only for birds. You can do it. That's it. Okay, so I want everybody to stand up, please. Again, if you're in pain, anything, don't worry about doing it. And you can feel free to come down here for this. It will only take a little bit, but you're more than welcome to come down. If you want more space, feel free. Or if you really want to be performative, anyone in drama, take a space, please. Okay, so what we're going to do is we're going to start by reaching for the sky and bend down to touch our toes for 30 seconds. So you can spread out, right? So reach for the sky and do this at your own pace and touch your toes. Again, at your own pace for 30 seconds. Okay. Now I want you to just walk on the spot for 30 seconds. You can jog if you want to. You can, side to side. But just keep moving. 30 seconds. Okay. Look at all you can do. Now we're gonna go back to our touching the sky and touching the toes for 30 seconds. Again, you're on pace, okay? Maybe try inhale when you reach up and exhale when you reach down. Focus on your breath a little too. My great starfish. Okay, now we'll do last 30 seconds and we're gonna do a little walking or jogging on the spot. Okay? Whatever you're comfortable. Again, you can move your gut. There you go, beautiful. Perfect as you like. Move to the side if you want, run, jump, you can find these. You do pull back and move if you want to. Make it your own, whatever you're trying. There you go. Yeah. The arm is moving still. All right. Amazing. Okay, you can all sit down again. Good job, everyone. Thank you. I'm glad you get these giggles out. Okay, so that was 2 minutes of movement. How is everybody feeling now? I think you know what? And I preach this, and so I know you here, because I have, I'm associated with some of the women of people that I teach with. And I preach so much about nonverbal communication. Over 90% of our communication is nonverbal. Why I say that is because even if none of you told me how you feel, I see the smiles, the reactions, the relaxed body language, like the positive reinforcement with the thumbs. So a lot of our communication is nonverbal, right? So I see how you feel, but it's nice to hear it as well.
I wish workplaces did this every morning after activity. It's really nice.
It is?
Yeah.
All right, hear that? Universal change across all the places you work. Let's go. No, it is good. Even just like a moment, like if you have an announcement at your, I know some of you may work in community, you're an outreach team, for example, but for those who work in hospital or in long-term care, like an announcement is a moment of mindfulness today. Today we're going to practice 2 minutes of exercise. Today we're going to practice a calm activity, like from the calm app, for example. That would be really good. I like that. Okay. Sure. Oop. There we go. Okay, now we're going to talk about. One second, this you know how to bust. I don't get one ahead of us. Oh, okay. Go ahead. There you go. Any questions about depression? Or anything we've learned so far? I was like ready to roll and stuff.
Oh, good, no worries. So what we consider depression is a state in bipolar affective disorder. So we're not going to talk about the depressive state of bipolar affective disorder because we just did, right? So when we think about bipolar affective disorder, it usually has 3 separate states that a person can fluctuate in between. Looking at the depressive state, which is everything that Brittany just talked about. There's the well state, which is the in between the depressive and then the manic state. So the manic state is the kind of opposite of the depressive state, where somebody is feeling some higher emotion, energy, and we'll talk a little bit more about that. Bipolar affective disorder used to just be called bipolar disorder. Manic depressive disorder is another older name or term for it. Recognizing that if you think about mental health on a spectrum and putting depression on one end or one pole, and then putting mania on the other opposite pole, that is the bipolar, right? The bipolar is between the depression and the manic state. There are 2 types of bipolar disorder. You have bipolar 1 and bipolar 2, and we'll talk a little bit about what the differences is between them, but it's more about where people land on the spectrum within their mood between depression and mania, sorry. And then if you consider the very middle to be a well state, we'll talk a little bit about that as well. I want to point something out here that oftentimes the word normal is thrown around out there very easily. I don't really know what the definition of normal is. I'm probably not it. So when I consider or use the word normal, for lack of a better term, or like a lot of people will say typical, which I think could be a little better, but also still not the best. If anybody has any words that they would like to use for the somewhat typical normal state, please feel free to enter it into the dialogue, because I don't really know a good word. I don't know either. It's a tough thing to describe. Anybody? Yeah.
The question I've asked is it's more that statistics are looking at the concept of neurotypical versus neurodivergent. And so many people classify as neurodivergent that the question is, what is then considered normative?
Exactly.
The fact that more people are neurodivergent than neurotypical.
And I think the other thing too is, okay, I asked for definitions of normal, neurotypical, normative. Right. So I want to just
go without saying that if I do use any of these terms, they are with a grain of salt. I don't know what that means really. It's just kind of this idea that something is not on either end, it's more in the middle, is what I kind of think about, especially when I consider well state. Again, what does that even mean? So just understand that language can be very challenging and it can also have different meanings to different people. And my intent is to never offend. So if anybody feels that any of the language that I do use is offensive, please note that it comes from a place of not just lack of knowing a better word for it. But I'm always open to have that dialogue, recognizing that when I say the well state, that's actually the language that is used in terms of the DSM. And I know that's probably not the best, but here we are. Yeah. Oh, the well site, yeah. Yeah, again, it's so, it's difficult. We're gonna use well state and I'm gonna use neurotypical, I guess, to an extent, or typical. Just so you guys kind of know where I'm coming from, recognizing that language is very, very small. So, bipolar affective disorder, we're talking about a spectrum. We're talking about one end being depression, the other end being mania, and then having this idea of a well or neurotypical or typical state in the middle. That can vary based on the person, but having to have some sort of baseline to kind of go through to actually discuss these three states. Every state has its own risk. Okay, so recognizing that we did talk about the depressive state, we know a couple of things about that already. So we're going to really concentrate on the high state. So when we consider the high state or the manic phase or the mania state of bipolar affective disorder, we are looking at almost the opposite end of the behaviors. People are feeling extremely energetic, almost euphoric. They have this exaggerated self-esteem. They may feel, again, like they are on top of the world. Whereas if you can compare that to some of the feelings that people are having in depression, it's very much like the opposite end of the spectrum, right? So they're feeling very talkative. They're having racing thoughts. They really want to get things done. They feel like they don't even really sleep. They're just having so much more of this exaggerated behavior and belief. And it's really difficult sometimes to keep up with these. Now, what I want for you to realize, again, is that it is a spectrum. So the degree of this behavior may vary, and this is dependent on the type of bipolar the person may have. So if someone has bipolar 1, they are more likely to go to the extreme ends of the poles. If they are bipolar 2, they usually have what is known as a hypomanic phase, where it's not as exaggerated, but it's still in that realm of this side of the spectrum. Does that make sense? So it may not be as pronounced, exaggerated, and it may not be as extreme in terms of some of the symptoms that they show, but they're relatively higher than the well. They are at least higher than the wells. Okay, so they have oftentimes when people are feeling in the mania or manic side of things, judgment can be very difficult. I don't know, like the only way I've ever really been able to compare this in my own brain, has anybody ever been really super excited about something and it almost ties into this idea of generosity, like where you're feeling really, really excited, you want everybody else to be excited, so you're like, do you want things? Let's get, like, I'm willing to give things. I don't know if that's maybe I have bipolar too, I don't know. But this is the thing, but I'm like, I get really excited, like, I'm really excited, and I'm just like Oprah, like, you get a car, you get a car, you get a car. Right, so I want like he put this time into emotions of kind of like you're not really thinking logically about things because you want to just indulge in lots of different like hyper feelings or exaggerated feelings. So people can actually engage in very risky behavior because they're not evaluate. It's almost like their id takes over. Does everybody know this idea of the id and the ego and the super ego? The id is like the pleasure center, and it kind of just like
Yeah. Like
addiction, exactly.
Instant gratification.
Instant gratification. It's not really using up the evaluative part of your brain. It's more about instant feelings of dopamine and
Yeah.
woo,
Yeah.
right? So a lot of that can be very present in the manic phase of bipolar disorder. But that can also affect a lot of things for people because the adage really, and when we think about bipolar disorder, is what goes up must come down. So when people are high in bipolar disorder or manic, often, well, they will at some point fall into the depressive state, and it's not linear. So someone may go from a mania into a depression, into a mania, into a well state, back to a mania, back to a well state, back to a mania, back to a well state, back to a mania, back to a depression. There is no, it goes here, 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 here. There's no like line. And so people can actually make decisions in their manic phase, really mess up things. A couple examples is we had somebody who would go into a manic phase and spend all of her money on fresh flowers. She would order thousands of dollars of fresh flowers to the long-term care home. So it would put her to the point where she couldn't afford her rent or afford her medication or afford whatever. And so it got to the point where they had to come up with a plan in her well state where they would actually, well, they would try to manage the medication to try to balance it out, but sometimes things don't go as planned. And when she was in the well state, they made a plan that they could take her credit card when she was going to leave, so that she wouldn't use the online flower shopping. We had another person who would often bring in different sexual partners. So people would have very risky sexual behaviors or have a little bit more like promiscuous behaviors and more likely to have unsafe sex. Because often people have this feeling of almost invincibility. They feel like they can't be harmed because they just have this exaggerated sense of esteem and self. And some people even believe, and this is where the delusions start to come in, that they have superpowers. So my earlier theatrics of I can fly was a real situation of somebody who had delusions in mania, believing that they could fly.
Is there some overlapping with BPD?
So borderline personality disorder? No.
No, there's okay. It's the risk. I was just thinking poor judgment, risky behavior.
Yes. So the borderline personality disorder, the reason behind the behavior is completely different. But I can see, and it's also funny because it's like, it's also the BPD, the bipolar disorder. And people use that. Yeah, the cluster B, and we're gonna do personality disorders, and it's
Okay.
it is a whole other world. Let me tell you, it's my favorite section of this training. Very interesting, very frustrating in many ways, but also really fascinating. So when we consider depression and bipolar disorder and anxiety, which we'll also be talking about, these are, they're classified as, oh my gosh. What is the classification? So there's psychotic disorders, there is personality disorders, mood disorders. Thank you. I couldn't think of the word mood. I'm like, emotion? No. What am I getting at? So these are mood disorders, so the disorders of mood, whereas when you have personality disorders, the disorders of personality, and then when you have psychotic disorders, they are disorders of psychosis. And so in these, it's the mood part that is actually the afflicted section or portion of the brain. Is the mood is what's directly kind of, I want to say it's kind of affects So when we consider hypomania, it is a step above the well state, and the person may feel really good, but usually they're not experiencing any of the delusions and possible hallucinations. They don't usually become psychotic. Those who have bipolar 1, that's kind of that step apart, is that they have a higher psychosis rate because of the extent or the extreme of their mania. Does that make sense? Okay. So the well state, as we understand, is basically the in-between. I guess you could use the baseline for the person. If like they're not at either end, it's more the middle phase or the typical phase or the well phase. But that also comes with its difficulties as well. So if we think about depression, what do you think is the biggest concern when we're worried about depression? Suicidality, right? And especially when someone is living with bipolar disorder and you think about this whole thing about what goes up must come down. If somebody has bipolar 1 and they are in the hypermania, there's a long way to fall. It is a huge fall. And so people who are living with bipolar 1 are more likely to experience suicidality as well. What do you think is the biggest risk in a high state? Yeah, self-harm, risky behaviors, psychosis that could lead to self-harm, or not even intended self-harm, right? So that's the other thing too. Like if I were to say, I believe I can fly, and I actively jump out of the window, is that considered suicide? No, because my intent wasn't to die. My belief was I can fly. It was an unintended outcome of my activity, right? So again, recognizing that the intent behind the behavior would be different, but still is risky. Now, what could be the problem or the risk of the well state? Yeah.
Being lucid and knowing what we just went through.
Yeah, so absolutely, you can have that in looking back and reflecting on the past behaviors, whether from the manic or the depressive state, for sure. There's one major risk. All right, let's think this through. So if I have a cold, and I got a cough, what do I take? If I stop coughing, you might be taking cough medicine.
No,
That was the risk of the non-compliant. So when people are in a well state for a longer time, or they're in there for a bit, they believe they're better.
Yeah, right.
So they start to become non-compliant with meds. They could, I'm not saying everybody, they could. That's the risk, is that people are like, oh, I don't know, I'm okay. It's been so long. I must be good, not recognizing that that's what's been keeping them in the well state has been the medication regime. And if you guys are interested, I don't know if any of you know, not Edward Munch, that's the painter. Robert Munch, that's the guy. So he was the child author. So remember Robert Munch? That's right. He lived with bipolar affective disorder. And he used to talk, there's actually a bunch of videos of him on YouTube, and he actually talked about how he would believe that he was better when he was in a well state for a while and try to go off meds, and then he would go into a mania. And he was saying, I would write in a couple nights hundreds of books, but the quality was always crap. Just pumping out all this stuff, and it's like, what the hell is that?
Isn't he doing the thing? Or did he already do it?
Oh, me?
Yeah.
Really?
Yes, he wanted to do that. I think it was a recent thing, I'm not too sure.
Oh, I can look that up.
Yeah, it's also like, who has bipolar, I don't know if anyone watched Star Wars, like the old Star Wars.
Yeah.
The main actress, the princess.
Oh, Princess Leia. Oh, Carrie Fisher.
Yeah, so she had it for a long, she did the electrical stuff and all that stuff.
EMT and all that, yeah.
So when her daughter passed away from the ski accident, it went even worse, and then she passed away shortly after.
Look at that, eh? I know she had an autobiography I always wanted to read called Wishful Drinking. So yeah, very, very interesting life too for her. So thank you. I didn't know that about either of them, to be honest. So those are the three main points in terms of the different states and what we could be seeing as risks. Recognizing that again, if someone believes they're well, why would they continue to take medication? So that's usually the biggest risk when it comes to the well state. So when we consider the bipolar diagnostic criteria, we are looking for a person must have experienced at least one episode of mania, right? So that's the distinguishing feature between depression. If somebody only has a depressive episode, then they're usually not diagnosed with bipolar because it's that contrast between the mania and hypomania. So we have the mania piece is looking at that elevated, expansive, or irritable mood must last for at least 1 week, present most of the day, nearly every day. And if it's to be considered hypomania, the mood must last at least 4 consecutive days, be present most of the day, almost every day. And during the period, 3 or more of the symptoms must be present and represent a significant change from usual behavior. And the symptoms that they're talking about are these here. So when we consider bipolar 1, it is again the presence of the hypermania or the most extreme mania. And if we consider bipolar 2, they at least have hypomania. So it's usually the depressive episodes and the depressive symptoms that the person seeks help for, because the hypomania doesn't seem as exaggerated or as I guess more detriment to their lives, to their everyday lives, whereas the depressive episodes tend to be a lot more rough on. One of the other things I just like to mention in terms of any mental health diagnosis that you see, besides the psychotic disorders, every single emotion that people experience in mental health conditions, we all have the potential to feel. We all feel sad. We all have down days. We all have happy days. We all have excited days. The difference between having emotions and varying emotions at varying times and what constitutes a mental health disorder is, what do you think is the line? So like, if I can feel happy and exaggerated, how come I'm not considered bipolar disorder or manic?
I think it's how long you are in one state and the things that you actually do, if it's doing a harm to yourself and others around you. I think that's how we're convinced to be.
Yeah. So this is the other big piece about mental health and why we talk so much about resilience and coping. Because it really does. The line is it affecting your life? Is it stopping you from doing things? Is it stopping you from going to school, going to work, having relationships? That's the only defining feature. If you look at a lot of the DSM criteria, it's the length and the detriment, right? So, and we'll see from anxiety disorder as well, like it's a long time that you have to show symptoms because anxiety is such a normal feeling, right? And again, normal. But what we have to consider is really, people could experience different types of emotion and have different ability for resilience. It may not affect them as much in terms of what's happening in their life. Not to say that people choose whether they have mental health disorders, but it's looking at every single one of us has what it takes to be pushed over that line, right? None of this is really anything that's like, you're a defective human being. It's like, no, we all have this potential. It's what we're faced against based on our resiliency and our ability to manage in everyday life. And if by some chance, there's some things that can take us over the edge in terms, especially when you consider depressive episodes. You can have depression diagnosed at any point in your life. It doesn't have to be, I'm 40 now. Okay, I'm safe, I'm free. No, it could be up until you're 97, you're gonna become, that you have your first depressive episode. So recognizing again that all of these different things are emotions and feelings that we all have or have the capability of having. It's based on resiliency and it's also based on chemistry. But that's the other piece too, and biology, right? But there is no cookie cutter recipe. Nobody really knows how any of these different mental health disorders are created. It's not.
They say, a serial killer is not born, they're made.
100%.
So same thing. It takes a long time to even, be diagnosed with schizophrenia itself, a long time. You can't decide that they're trying to figure out which one, and I'm going to talk about it later.
Oh, you mean personality disorders?
Yeah, or schizophrenia itself, like starting to be diagnosed with it, because I know someone, family member who's going through it, and it took them almost a year or so. Because, like, even though there's multiple hospitalizations, all these things, well, because it matches so much other different types of other diseases, and so it took a long time to actually have the schizophrenia. Absolutely.
And even to it, well, and we'll get to some of the nuances about particulars when it comes to diagnostics, but it's also almost like, do you want to know?
Yeah, right.
Right? And some people will fight against even getting the diagnosis. Some people will fight against giving the diagnosis because sometimes it's the diagnosis alone that creates the label, and people are really, really concerned about having these things attached to them.
Yeah.
I will be honest, like I remember when I first got into nursing and I was worried. I was like, oh, like if what if something were to happen to me in terms of like my mental health, would I be able to work? Like, and if I were feeling that way, and I was diagnosed at a very young age I know a lot of people find this kind of wild, with a major depressive disorder. So I've been on medication since I was 17. But looking at that kind of thing, and when you're choosing nurse as a profession, you're like, oh, if people know that about me, are they not going to want to hire me? Am I going to, do I have to disclose this information? How blah, 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 blah. Because it was, again, so stigmatized, and it still is. I think about you.
What happens if one parent?
Oh, perfect.
Yeah, yeah.
Absolutely. I think it's one of those big things too, when you do a bit of research and you have a little bit more education and you start to look at the commonalities and the differences between certain mental health diagnoses, you realize, oh, this just sounds like everybody I've ever met. Like, okay. I'm pretty sure I've diagnosed myself with every single mental health condition possible. At some point in my life or another, because again, they're relatable because they are emotions that we all feel. Even if we're a transient moment of time, we're not all glorious and wonderful, good-minded people 100% of the time. Sometimes we feel upset, sometimes we feel angry, sometimes we feel happy, whatever it might be. And based on our experiences, like honestly, when we get to personality disorders, I diagnose myself with every single one. All of them. Yeah.
It's actually quite funny if you think about the fact that there's quote unquote no stigma around physical illness, and yet mental illness is often significantly universal. Everybody's going through something at some point, or relate to more of these things than you can necessarily physical skills.
Right.
Right, but it being an invisible disability makes it, yeah.
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 Someone on the street. Someone on the street, guys. And this is obviously, it's the very start of my knowledge. How. All of the things are just found out. Right, you know, yeah, so they explain to you all the, we talk about all the physical things, you know, I go off about it. That there are physical presentations, but unless you're on the well, those talk about them, you might not sit there. Oh, you know, they sometimes when I get those, my whole chest will get red and water, which is why you sleep by not. Not, okay, I'll wear something that you should probably. Now, but like, yes, you can see the. But it's not the same as having like it's like in rain, it goes on, that's great. If I told you I had arthritis, it's that's a lot. But if I'm like, yeah, a lot.
I get it all the time. People always are like, but you're like so energetic and so happy and so like, how could you possibly live with depression?
I like live with, yeah, like I suffer from GAD, so generalized anxiety disorder. And I realized it was, my inability to regulate my emotions, and it was causing such distress. And people, the same thing, well, you don't seem to, but it's like, at my face, I know typically I'm not, but, those, feelings of fear, I'm not always able to regulate by myself. So that's where medication has helped in it. You're able to live, to me, a fulfilling life and a greater quality of life. So yeah, I'm glad we're all open with speaking about that.
Yeah, absolutely. And it took me a long time. It took me a long time to be able to say it out loud to a group of people. Like, again, I'm 40, so when I was 17, you're looking at the early 2000s,
Yeah.
still not 100%
There's no me
safe
too.
zone. I just feel,
Yeah.
People are very scared of dogs.
oh, 100%. Yeah, absolutely.
1 in 5 is the statistic of dying.
Yeah.
Walk around and we're positive about the where they get home. We're able to long wait time, but according to I was looking at the will there work at the I can't go, I go to the shopping and papers we have always my.
Yeah.
All of it there. And 1 in 5 diagnosed.
And learning to map, which is so exhausting.
Mm-hmm.
Oh, you come home from work, you take off your mask. It's just, yeah.
Well, and that's the big thing too, is part of, I feel like the education and the work that we do, even in this sport, is to try to take uncover the veil or take the veil off, right? Because all of us, and then whether you're comfortable with speaking about it or not, probably have been touched by some sort of mental affliction, either personally or through your network. And recognizing that like sometimes just having this experience where you're seeing someone open up so courageously and also just so freely with their own experiences, that can create confidence in other people. So I think and thank you so much for sharing your experiences. And you're more than welcome. I don't like necessarily to say I like to create a safe space. I feel like safe is subjective. It's for what you feel. I can't tell you if you feel safe. But I want you to know that we come from a place of openness in terms and acceptance. So if anybody wants to talk about anything, and I hope we can have an understanding of this room, this very large state. But I mean, always feel like, or even if you want to come to us after a talk, always good for that too. So if it wasn't hard enough on people who are living with bipolar affective disorder, you can also experience mixed features, which I found like, I don't even know how a brain would do this, to be honest, where you're feeling both sides of the poles at once. So you're having this mania as well as this like depression. And I feel like that's so conflicting, and I don't really like, I don't even, it doesn't even make sense in my brain how that could happen. But it's usually with comorbidities such as addictions and substance. So when people are experiencing or utilizing substances to try to cope with other experiences, it can often quickly shift. So we all know that people can use alcohol to cope with certain things, especially in depression. It's a huge coping mechanism for people. And alcohol is a depressant. So oftentimes people will use a depressant to treat or cope with a depressant, and then obviously perpetuate the cycle. But other drugs that can be used to cope are things that do break. So things like cocaine or other types of hallucinogenics that try to offset depression can often bring in mixed features as well. So it's not just substance use. Some people can also have this idea where they are having a major depressive, but have some symptoms of the mania, or it could be perpetuated by a substance disorder. So when we consider popular treatments for bipolar affective disorder, usually it is a mood stabilizer. Something like lithium is often used for people who experience bipolar 1 with hypermania. If someone has bipolar 2, they're more often use an antidepressant. They don't use antidepressants in bipolar 1 because that can tend to jump people into manic phases. And the mania, if you're bipolar 1, the risk of the psychosis is what is the bigger risk. So they don't want to actually utilize antidepressants that could jump someone into a manic phase. In bipolar 2, the mania isn't as exaggerated. It's usually depressive symptoms that people come and seek help for. And that's what's the riskier phase for them. So often they'll use antidepressants in bipolar 2. Does that make sense? In terms of bipolar 1 with lithium, it is a high-risk drug. You can get lithium toxicity. So they have to get constant blood work, which can be, again, an added stressor for somebody who's living with mental health. So often people don't want to use lithium because of the added need for medical attention, maintaining lithium toxicity levels. So it can be a bit more strenuous, but if they are following the regime quite well and they're used to it, then that tends to be the most effective. Recognizing that there is an 80% chance of relapse if people go off their medications, that is again bringing the attention to the well state. If someone is well, it is often needed for continued support in keeping them on their medication regime and reminding them that the well state is probably or could be mostly dependent on the fact that they are. There?
Would that be for bipolar 1?
It would be for bipolar 1 where they're having instances of psychosis.
Oh, okay.
Yeah, so in bipolar 1, when somebody has an exaggerated hypermania, there's usually a higher instances of psychosis. So they'll be put on, like, because they're having the delusions of the hallucination, those exaggerated. Usually in mania, you'll see very, almost like superpower delusions and hallucinations, whereas in depression, they're more negative because that's where the brain is kind of going. So again, the hypomectin fly was a manic delusion that somebody believes. So if that's the case, we're giving antipsychotics for sure. Yeah, great question. So some supportive strategies, we're looking again here, focusing about mania. A lot of it is about not and this is for anybody who's experiencing psychosis, you never confirm or deny. And we'll talk specifically about that when we get to the schizophrenia piece, which is the psychotic disorder, how to manage somebody who is actively psychotic. But considering that if there is somebody who is in a hypermania and they are experiencing psychosis, we don't want to say, no, you can't fly. Because they'll say, well, yes, I can, let me show you. And of course, you don't want to say, yeah, you can fly. For obvious reasons, right? So we say, it sounds like you believe you can fly. I don't believe that, I haven't seen that, but maybe you would like to tell me, and if they're in a place where it's unsafe, maybe you'd like to tell me about it and try to coax them into somewhere. Like, you're not going to say, well, let me try to talk to you where you can't jump. Like, we're going to be like, well, let's talk about it somewhere quieter and go downstairs or whatever it might be, right? So you're going to try to move them away from danger. If they are actively trying to jump out the window, you're calling the police right away, right? We're getting people who can come in and help support us, or we're calling a code white and we're, you know what I mean? But we're not just going to go, oh, okay, I see you're trying to jump out of the window there. I'll just stand back here, right? Well, no, we're gonna engage. But we want to reduce the environmental stimulation. We don't want to challenge what they're saying, right? So we want to kind of say, it sounds like this. I hear you're saying this. I know that you believe that you can fly, but I'd like to have a bit more of a conversation about this, maybe downstairs where it's quieter. You want to set boundaries and keep your team approach consistent. You want to try to keep off of emotionally charged topics. Because remember, this person is already emotionally on 100. So we need to try to keep things a little neutral. We don't want to get something that's going to jump their emotions or kickstart more emotions. We want to reassure using positive body language and validating words and focus on one task or topic at a time. People who are in a manic phase will jump, right? So they go, but it's over here, and then I have to go there, and then there's the work, but then there's this, like they want me to go there, they need me to be there, and then I have to go up to Spain because I'm the only person. So you're trying to bring them back to one topic to maintain focus, right? So you want to go, oh, you were saying you had to do that work. What is that work? Oh, you were mentioning about the work. Can you tell me more about that work again? Oh, you jumped again. Can you go back to the work? So you want to keep bringing them back to the one topic. Still just keep the tangent. Yeah. The other thing is to try to not take things too personally because they will think that you're too slow for them. Their brain is going 100 miles a minute and you keep talking about the work. They've been past that. I'm past that now. The work's already been done. Didn't you see? I've already done it and it's great. They already like it. Stop it. Right? They're going to get frustrated. So you have to try to, again, stay neutral because they will mood jump with you. So you have to try to not mood match them, which is a really hard human phenomenon to go against. Humans are mood matchers. We're mirrors. We are mirrors. We like to mimic what we see, and body language is so powerful. So we have to try to keep that. That's part of the skill when it comes to this work, is maintaining that composure. And then obviously, if the person is causing any risk to themselves or others, we're forming and we're code whiting, we're calling community services, we're calling police, whatever we have to do to protect that based on policy of where you are to make sure that people are safe. Okay. So again, resources that you can access, and then also references. And what time are we at now? All right, we're at 11:51. Do you want to do anxiety or lunch? Yeah. So we'll do one more section, then we'll go for lunch. Is everybody okay with that? Okay. We're gonna go into anxiety disorders. And then I just want to ask you guys, how many people here have brought a lunch? Or how many people are gonna go out and grab? I'm going out. Okay. How long do you think you'll need for lunch? You want to try? I'm just wondering. We have up to 45 minutes. I think 45. Everybody okay with 45 minutes? Okay. I think that would be good too. I'm gonna go out and grab lunch. There is some of the cafeteria on this floor. There's a cafeteria. It's not on this floor. You just go down the stairs, and it's just around the corner. Did everybody see the market what they talk about, the marketplace where they're selling like drugs or other things. It's around the corner, but I'm gonna go, I'm gonna head that way, so. Okay, okay. All right, ready? Oh. Okay, yeah.
Yeah, there's actually a ton of here. All the way down. Okay, everybody, we're moving on to anxiety disorders today. So, when have you experienced times of anxiety? If you're comfortable sharing. Okay. Right now, 5 minutes ago.
From birthday week and their birthday celebration, that graduation, and then I had to do work, and then also I have carnival, vacation. So it was like a lot of things, and then my health, and so it was just, and my dad was like, because no one was listening to me.
Active listening, the importance of that.
Right, so then, well, things weren't going as planned.
No, for sure, that's where anxiety comes from too, a lot of the times, right, is when there's unpredictable aspects, like when it's not like it's not predictable, and you have a vision in your mind, so, okay, my day's gonna, this day's gonna go like this, is gonna go like this, I'm gonna do this, and then all of a sudden, a wrench is thrown in your way, you're like, that's not prepared. I was not ready, I had and so, yes, exactly, thank you for sharing. Go ahead. The oldest thing, and then one time when we never go starting to go. Sometimes it's just pulling off the other. My God always says it's like something like a hot pen and then like a lot of stuff. Yeah, now that's what feel. It's like it's really good. It wants something. Right? Does anyone else want to share? This could even be, it doesn't even have to be, it could be a personal experience, but it could also be like one of people's family experiences. That's so broad. Like think of like job interviews. A lot of people experience anxiety. Think of like general broad things too. When do people experience? Pardon, sorry? Anything new from the small? Yeah.
Public speaking.
Yeah. Speaking, yeah. If everything was becoming a PRC, it was this part of your job, and it's not like this. Either learn to cope, or this may not be for you. But yes, exactly. Public speaking can be a huge cause of anxiety for a lot of people, for sure. Does anybody else want to share another one? Before I move on to the next slide, if not, that's okay. There we go. Okay, so today we will be going through the 5 types of anxiety disorders. While there are many different anxiety disorders, these are the most common amongst the population that we support. So these will be the ones that we're reviewing today. We have generalized anxiety disorder, specific phobia, panic disorder, agoraphobia, and social anxiety disorder. So first we will review the DSM criteria for anxiety. So excessive anxiety and worry, apprehensive, this is for generalized anxiety disorder. Apprehensive expectation occurring more days than not for at least 6 months about a number of events or activities such as work or school performance. The person finds it difficult to control the worry. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms present for more days than not for the past 6 months. So this includes restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbance, so difficulty falling or staying asleep, or restless or unsatisfying sleep. Then we're going to go through the signs and symptoms of generalized anxiety disorder. What differentiates the different types of anxiety, though, is the trigger. So again, we're going through things like agoraphobia,
specific phobias, social phobias, so it differentiates the different types of anxieties is the specific trigger. With generalized anxiety disorder, what do you think are some of the common triggers with somebody living with generalized anxiety disorder? And when I say common, I know it's kind of like using the word normal because, in a sense, because everybody is different, everybody may present differently. So this is what generally the more common. What do you think? Pardon? Irritability. Okay.
What would trigger?
What do you think some of the common, sorry, yes, the common triggers of somebody? Okay, yeah. What else? Stress, yeah. Yeah. Change, yeah. Losses, yeah. Yeah. So some of the common ones too, job security or performance, health, finances, the health and well-being of their loved ones, being late, or performing responsibilities. These worries can often be observed in the signs and symptoms of somebody living with GAD. However, you may also see these in other types of anxiety disorders. These can also be signs of medical conditions, GAD. Pardon? Oh, my bad. The one time it works without me pointing at it. Okay, these signs and symptoms can also be signs of medical conditions. It is more, GAD is more likely if physical health issues have been ruled out through history, physical exams, and or testing. So we do want to remember before diagnosing, of course, this wouldn't necessarily be at our level, but maybe our observations, little tests we've done along the way, or assessments we've done along the way will contribute to the overall life. But we're obviously not going to be the ones that bring our residents, but these are things that can contribute and that we can look out for as well. What are some behaviors you may see that could be due to anxiety? So what things might people do that could signal they're having anxiety? Shallow breathing, yeah. 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 Watching some skin, we're able, yeah. Yeah, yeah, maybe.
Hyperventilating, or like,
Some people would drive stuff in their home, fidgeting, exactly. Pardon? Sweating, right? Excessive sweating too, even just a little bit of sweating. Sometimes we may even see it in our body language too, right? People may go like this, they kind of like, they may have their hands crossed or their legs crossed to kind of calm their nervous system as well. Pardon? That's what it is of an and that we can see. Yeah, exactly. So yeah, those are some of them. It could include also so what might we see in our residents? What behaviors might we see in our residents with anxiety? So I know some of you work in community, hospital, some in long-term care. So relative to your setting, what might you see in the older adult setting? Yeah. Great piece of advocacy. I love that you're using strictly words and not agitated or aggressive. Thank you. Person centered, yeah. What else? What other things might they do?
Like the response behaviors. That makes sense. Preference over the again. Looking for stirring.
yeah.
There all the time.
Exactly. Sometimes pacing, pulling the call bell.
Yeah, I found them sometimes people have, you look at them, and what's the problem,
Sometimes that could be attention that they want to do. Yeah. Exactly, not wanting to join group activities, not engaging in personal affairs, everything else that you all need. Exactly. Oh, all right, wonderful.
example. So. Okay, so what would an example of an animal phobia be? But, yeah, exactly, exactly.
I don't. If I have to walk 5 minutes, I will, because if I have to park under a tree, someone has to come and search my car.
You know,
That's how
because
that-
you know there's gonna be a spider out there all the time. Oh, you know what? One time when I worked in long-term care, this girl that I lived beside in my building before, she also worked in the same long-term care home as I did. And I'm driving, okay, and we're almost at work. I see a spider hanging down, crawling across the windshield. I was like, you better kill that right now. She was like, what do you want me to kill with that? I'll figure it out. Like, I'm not driving safely like this. And I hate when people do this, okay? When I tell you, no. When I tell you kill it, okay? I don't want you sitting there taking your hand. Oh, this isn't the time to be Mother Nature. No, okay, I'm driving. You want me to get you there safely and myself there safely? This is not the time to be Mother Nature. All right. No, so she swapped it. She takes like something and she goes like that. I was like, where did it go? She's like, well, I don't know. I thought I was like,
What do you think of all this?
ain't none of us showing up to today's shift.
I was like, I was like driving on my square, and I was like, I saw my visor, and I kept punching. I exited actually right here, somewhere on Bathurst or Allen. Yeah. Because I was going to Hamburg Hospital, and I jumped on
I
the
used to
car.
work there too.
Yeah, and I had to stop random strangers to search my car. They were looking at me like a crazy person because I had a whole panic attack. Yeah.
Not for me. We obviously it was fine. I think the spider like died or she got it after, but it's still that like that is not a time. Don't if it's in my house and you want to take it outside, no problem. But if we're in the middle of driving, you are solely responsible for making sure that it's dead and gone in my car. Okay, natural environment. What's an example of a natural environment phobia? Pardon? I just elevator. So natural environment. Yeah, so I think of nature. Pardon? Thunderstorms, raining, yeah. Snow. Okay, yeah. Could be. So maybe like, so yeah, storms, exactly. Open air, fire, tsunamis, right? Some people have a fear of that as well, tornadoes. What would an example of a medical care phobia be? Injection? What was that? Sorry, I'm hearing a mix of things. Yeah. Did you know that during the pandemic, there was actually, so when you were getting your vaccine, there was actually injection sites specifically for people who had a phobia of needles? Yeah, I didn't know. Yeah, that was right in there. Yeah, and I was like, that is so nice and so thoughtful that people do that. I don't know where it was, but I just know they had them. I remember hearing about it. What about a situational type of phobia? This is where the elevator one was from. Off the flying, yeah. Airplane, yeah, maybe flying, height, situation, right? So phobias are broken down into cognitive, physical, and behavioral signs, like they affect behavior cognition, or no, cognitive, never mind, cognitive, physical, and behavioral signs. So cognitive sign you might see, for example, is if I fly, the plane will crash. Physical signs may be sweating, nausea, dizziness, and behavioral signs will feel like they have to escape to avoid the phobia altogether. Think of like Final Destination. Now I know that's a horrible example because anyone who's seen the Final Destination movie is their worst fear does come true. But it's like that fear before, like if I go on this plane, it's gonna crash. Like I'm literally not gonna go on. You don't understand. The plane's gonna crash. None of you can go on this plane,
right? So the cognitive is like the plane's gonna crash if I go on it. But that is also like maybe that's specifically going on. The behaviors of you can't go like the sweating, the constant ruminating of thoughts, and then the behaviors, maybe they just avoid the flight or altogether. Some of the common treatments for it is CBT, so changing the way you think will change your behaviors. And then exposure therapy, so sometimes this is done through something called the systemic desensitization, where you start with what you're least afraid of about it to what you're most afraid of. So it's like, okay, if I had to rate it, I would be most afraid of actually going on the plane. I would be least afraid of maybe seeing photos of the plane. And then you slowly work your way up and expose yourself gradually, of course, with a therapist. Relaxation training, meditation, and supportive counseling. So this is an example of where you practice focusing on your breath and deep breathing and relaxing during these situations, because obviously this can be very anxiety inducing. So just practicing focusing on your breath, being in the moment, practicing being safe within yourself, is an example of this as well, and supportive counseling, so like talk therapy. There we go. Social anxiety. Did I already skip past that? No, I didn't. Okay, great. All right. Social anxiety disorder. So the physical symptoms and treatment strategies for social anxiety disorder are the same as generalized anxiety disorder. What do you think a trigger could be for somebody living with social anxiety disorder? Pardon? Isolation, they don't want to stay out, they don't go out, they want to stay in. We actually sort of no, this, yeah, the trigger. So I realize I keep saying, I'm like, yeah, that's simple, yeah. Signs and symptoms of a trigger thing. Or a trigger would be having to walk situation, reduce yourself, icebreaker. Yeah. When you're put on the spot for things like that, right? Where you're told, okay, we're gonna go into breakover, you're gonna have a partner assigned to you today. And it's like, oh God. Oh God. Right? What else could be a trigger? Camera, yeah. Maybe taking your photo or asking to videotape you. Yeah. So things like professional or personal gatherings, meeting new people, working in groups, schoolwork, school or work, having small talk, group activities like recreation therapy and long-term care, communal dining, and often people with social anxiety will avoid these types of situations. So next up is panic disorder. There we go. Okay. So, these treatments and strategies have been covered in previous slides. For panic disorders, it's important to mention that oftentimes the trigger of the panic disorder is unknown to the person. A panic attack is described as an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or more of the following symptoms occur. So, palpitations, pounding heart, accelerated heart rate, sweating, trembling or shaking, sensations or shortness of breath or feeling of being smothered, feeling of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded, or faint, derealization, feeling of unreality or depersonalization, feeling of being attached from oneself, fear of losing control or going crazy, fear of dying, horrendous, numbing or tingling sensation, chills or hot flashes. In addition to the treatment and strategies listed here, grounding techniques can also be helpful. So they are, for example, CBT, relaxation training, supportive counseling, with the most effective treatment being medication combined with counseling. So a lot of the same as what we learned about before as well. There we go. Agoraphobia. So agoraphobia, the treatment and strategies for agoraphobia are the same as panic disorder as well. So I'll give you a moment to just read the slide. It's a very short one. And then we will move on to the next one.
Everyone done? Yeah. Cool. So typical treatment. Okay. Typical treatment for anxiety disorders is CBT or supportive counseling. So this assists in CBT. It helps with cognitively restructuring the brain. So by changing our thoughts, let's say we all usually have a phobia of spiders, right? You want to start looking at changing your thoughts around spiders. So okay, the spiders in Toronto specifically, none of them are poisonous, right? So if what is our fear base around them? They're small, well, your stomach larger than them. They have 8 legs. They are 100 times bigger than them. You can step on. They're not faster than, right? When you're looking at it, being like, I can do this. Okay, I've seen people kill spiders in videos. I've practiced killing a fake one. I'm capable. If I just take a deep breath before, I've done it before, right? And just changing your way. And then every time you approach the situation going forward after much practice with it, it's not easy. After much practice in a structured setting, right? You're like, okay, I know it, right? I'm making it sound so simple and easy. I'm very well, and it's not. That was just a very brief example. One of the goals of CBT is to help the person rewire their thought processes and reduce mood and anxiety symptoms. We know that CBT is a helpful treatment for people living with anxiety disorder and can potentially help those living with depression and personality disorders too. Supportive counseling can be provided by various trained professionals and can be in person, on the phone, or virtually. So for example, like occupational therapists, social workers can provide social supportive counseling. Psychotherapists as well, of course, can provide supportive counseling. There's many nurses, RPNs, RNs can also go into the counseling field as well. So there's like, you can pick a job specifically in that. So there's many fields and lines of work that are able to provide counseling should they so choose. And then you may see them in use, but just be aware that these are not the current best practice for, yes. Most common medications and classes would be SSRIs, SNRIs, and pregabalin. And regarding medications, these are the most common treatments for anxiety disorders. But please note that benzodiazepines are not preferred treatment for older populations. So things like lorazepam, they also can be very addictive. And then, of course, exposure therapy. This is done repeatedly with the person. So like I said, this is something like systemic desensitization, where you have a list of potential exposures and you start with the slowest, the smallest one. I'm afraid of vomit, and like not in a way that's like, ew, it's gross, or like nobody likes vomit. I've heard that my whole life. It genuinely causes me panic and a lot of distress. And so I've done the whole systemic desensitization thing with regard to emetophobia, if anyone wants to look it up. But I've done the systemic desensitization thing where you're starting out with you're least afraid of to like what you're most afraid of. And I can say it's been very helpful. So for anyone who ever wants to look into exposure therapy, it can be very scary, but it's also very, very, very helpful in my own experience.
One of the things just to mention is you may notice that a lot of the typical treatment for anxiety is also the typical treatment in depression. So there isn't a lot of long-term anti-anxiolytics, right? So anxiolytics are usually used in the moment. They're very fast acting. There's things that like something like an Ativan, which are supposed to be used kind of on an as-needed basis when things are pretty intense in terms of the anxiety. Whereas when you consider the treatment for like long-term anxiety, it's usually a combination with it's usually an antidepressant, because that helps with the long-term anxiety experience. So there isn't an actual like long-term anxiolytic, they're mostly about that. So that's why you might see like wildfire, so using anxiety meds for anxiety, and it's usually that anxiety medications are in the moment for something like that, which we will talk about, kind of attack or high experience that are more like acute. And anxiolytics are very fast acting and sedate, so they have a lot of side effects, which is why they're usually asked to use over things.
No, please not. That's something I'm not a nurse, so it's for you. Talk about that, please. No. Exactly. No, that's important to know. So supportive strategies. So we have exercise, as we know, and we experienced earlier with exercise, right? It creates the happy hormone, it creates endorphins. So by exercising, and I know that can seem so daunting sometimes, like, oh, exercising, right? Intimidated to go to the gym or try a class. I don't know, I'm not flexible. Exercising can simply be choosing to take the stairs instead of the elevator. Getting up and going, walking to the bus station today instead of taking the bus to the bus station. It could be choosing to go on a 5, 10, 15-minute walk today instead of sitting and doom scrolling on your phone, right? It doesn't have to be a full class or a full big commitment right now. It could just be something small, right? Or even getting up and standing from your chair throughout, just doing a few of those throughout the day, and just boosting that happy hormone. Deep breathing exercises, this naturally calms your nervous system. So what happens when we experience things like anxiety? Sometimes our heart is racing, 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 racing. It makes your body think, oh, we're exercising, right? Well, with exercising, when you stop, your heart rate naturally slows down. With anxiety, your mind's like, oh, fight or flight, there's a perceived threat, there is a danger, even if there's not. And so you have to manually calm your nervous system. And deep breathing really, really helps with that. And then it puts your brain back into a safe state, like, okay, we're safe, we're okay. The threat is not real. Predictable routines, again, like I said earlier, with anxiety, it is often, even like Samara shared, it's the unpredictability, right? Like, I don't know what's gonna happen next. You have all the stuff set up, like, okay, I'm gonna go here and do this is what my day's gonna look like today, then life gets in the way. You're on the highway thinking you're gonna be here on time, you get a flat tire, and you take a bus 15 minutes earlier than you normally would. The bus is now dilly-dallying and waiting at a stop, and now you're 20 minutes late and you're really anxious about that, but that's out of your control, right? So some sort of predictable routine helps ease that anxiety because you know what to expect. Reassurance, of course, we all like that. It's nice to hear, like even we had in this room earlier, us sharing experiences with each other at times where we have experienced anxiety or depression or challenging times in life. It's that reassurance that, hey, we're not alone, right? Like, yeah, I would feel that way too. Validation as well, great practice. General relaxation training, right? So sometimes there's this thing called, like, I think it's called progressive muscle relaxation. And to my knowledge about it, I would say do your own research though. I'm not in any means an expert, but practicing relaxing your muscles from like top to bottom, bottom to top, like actively going, okay, I'm gonna relax my jaw, I'm gonna relax my shoulders. I'm like going muscle by relatively, muscle section by muscle section and actively relaxing. Supportive social network. So this would be hard for people with social anxiety disorder or agoraphobia, but even just having people that you can connect with, right? So you don't feel lonely, so you don't feel isolated, having that feeling that you know you can rely on this one person or this group of people. Whatever that looks like for you. It could be friends, could be family, could be a religious group, could be a dance group, could be your colleague. Whatever that looks like for you. Healthy eating, as we know, healthy eating does improve and change your mood. I'm not here to tell anyone how or what to eat or that you should be eating a certain way. But as I said too, like for example, if you were to have McDonald's for 3 meals out of your day every day, it would naturally make you feel sluggish, right? It would make you feel tired. It would make you feel lethargic. And because you're lethargic, you bring your mood down. You're tired. You don't have the energy to do this, to that. Compared to if relative to you, your health, your goals, etc., you had a well-balanced diet. Deep breathing exercises, meditation, mindfulness, and of course, group-based therapy and support as well. So our last slide, lets me do it. There we go. We're gonna do a deep breathing exercise. So we know that deep breathing can calm us down naturally. It's one of the best ways to lower anxiety and stress in the body. Let's try it together. As per the University of Michigan, belly breathing is as follows. So we're all gonna do this together. I will walk you through the steps. You can close your eyes or you can leave them open, whatever you're comfortable with. And just sit straight, sit comfortably, or you can stand if you want, or if you are comfortable, There's a whole floor in front of you and a stage if you do want to lie down, no pressure. So I want you to sit or lie flat in a comfortable position. I want you to put one hand on your belly, just below your ribs, and the other hand on your chest. I want you to take a deep breath in through your nose and let your belly push your hand out. Your chest should not move. So take a deep breath in through your nose. Let your belly push your hand out. Your chest should not move. Breathe out through pursed lips, like as if you were whistling. Feel the hand on your belly go in and use it to push all the air out. Repeat this a few times and I'll tell you when to stop. Okay, one more. And then when you are comfortable, when you are ready, come back to your normal, your pre-existing position. So how did that feel? How's it feeling? See a little sleepy eyes in the room. So I'm glad that it's working. That's what it was meant to do. So that being said, we are done anxiety. One sec. Just one sec, because I do have one more note when this decides to work. Here you will see that there's a resource from Anxiety Canada. The Anxiety Canada website covers this, so that is no longer a resource. We do have a few other resources, so if anybody is interested, we can send those to you. Message that or add today or the coming weeks at some point. We want those resources. We're happy to send them to you. But just please do note that Anxiety Canada is no longer available.
Put a sticker with the.
Oh, they already did that. Okay.
Yeah.
Even better. Okay,
Yeah,
great.
you don't have to
Perfect.
follow.
Perfect. Thank you.
Yeah.
Wonderful. So, okay, so that's it. So we're gonna. That's really preemptive. Beautiful. So we are gonna go on a, I don't know the time exactly. I can't tell you.
You know what, we're gonna say that it is, well, it's 4:25. So is everybody okay to come back at 10 after 1? Awesome, okay. Leave at 10 after 1, please be on time. 1:10? Yeah, 1:10.
So, can you please let me see if you get the best of it? When you're going to give me, thank you so much.
Are you a pickle person?
Oh.
So, me, for Christmas, my husband got me, like, sort of your tail pickle.
Pickle people are like, there's it's not one kind. It's not like I like them around and having this
Love?
Yeah. Or you would-
No, you're not.
I'm like,
Yeah, I think it might. But that's our, we won't be long. No problem.
actually, I'm leaving my badge here. I don't know. I don't. I am a big falls risk. Like,
Well, that's why I was just friends.
I can't tell you the amount of times in my life, like, it's not that bad because I have to do myself. Like, I have a scar here on my knee. Oh my God, this is gonna be.